the same thing as in just that's the same thing as in the laparotomy. So the midline is anatomically the midline. Okay, so you go right through that. So you have equal strengths of the two heavy sternae, and it's easy to open it up next. So this is how you do the sternotomy next. So what are the other variants of the sternotomy that we can do? You can J it off, and this sort of a J would probably be useful in doing upper. This is an upper partial sternotomy, and it would be helpful in doing mixed areas, especially if you want to put in a sutureless valve and things like that. Next, you could half tee it off to the side as well for this upper median sternotomy. Some people would like to do a paramedian incision and try to cause the costofungal junction, but that I think is a little bit morbid. So this is probably what would help you with your upper median sternotomy. You can tee it off like this. This particular thing shows low tracheostomy, and a manubrium sparing T sternotomy is done to protect against wound infection in this particular picture that we showed you. This is a thing which is even more lower down. This is for lower mid caps. Okay, next one. Sometimes you can J it off just at the Ziffy sternum. This is to protect the blood supply of the sternum. So this would aid in a better healing, and it would prevent wound infection as well. So this was one of the papers that we found. So this is J-ing off just at the Ziffy and keeping the bifurcation of the lemma intact. Next. This is a sternotomy which I would advise you not to do. This is popularized by many. It's called a S sternotomy. And people would like to, think that the sternum, you get the sternum as two bits of a jigsaw puzzle and it will fit it better. People have shown in various studies that the up-down movement, relative movement between the two heavy sternae are not so much as in when you do a straight sternotomy, but this is what will happen next. It fractures. So this then would, get you way down on the safety rung. So I would not advise you to do that sort of a sternotomy. So you can T it, you can J it, but don't yes it. Next. So next. So this is the mid sternotomy that I talked to you about. If you want to do a sternotomy slightly to one side to have a preferential opening of the chest, next, maybe towards the left if you want to do difficult OMs, then you do a straight sternotomy 1 millimeter to the left. Next, if you want to have a better view of the mitral valve, you do slightly to the right sternotomy, but again, bang straight. We do not like to curve around on the sternum, so this is what I would advise you to do. So you go slightly to the right, and you would be able to do sternotomy, which will help you to view the mitral valve better, and especially when the LA is small, and you do slightly to the left, you will be able to view the obtuse marginals better. Okay. A few words about the peristernal veins when you are scoring the periosteum of the sternum. Normally the more constant veins are the Ziffy vein, which all of you would have encountered, and many times you put in a little sucker there, and the vein gets cut, and then you try to pass it, and the whole blood, the blood fills up that area, and it's really difficult for you to get a good cauterization of that. So this is one vein which normally people encounter previous. The other veins are the ones which are in the jugular notch. Sometimes the veins are a little bit away from the bone, in which case you can easily clip it. Sometimes they go touching the bone, in which case you can dissect it off and clip it, or maybe you can cauterize it. It all depends on the venous pressure and the size of the vein, which will enable you to decide what exactly you would wish to do. So these are the two things. And if you exactly cauterize the vein on both sides, then it does not bleed and you don't lose blood, and at the same time you don't have to char a lot of tissue. trying to, you're to get hemostasis. Next. So the important thing is to use a proper coagulation current. Next. So the different current forms, waveforms of the available coagulation have been shown here. If you have a very uniform wave, like the top wave, that's a pure cutting wave. So it just cuts. It doesn't coagulate much on either side. So you do not get a good hemostasis. If you use a coagulation current, which is like those diamond feathers on the second rung, you get a good amount of coagulum of the vessels on both sides. And when the vessel gets cut in the middle of that, it does not bleed. So use a pure coagulation current. Some people may use a blended current, which uses both waveforms, but I personally prefer pure coagulation current, and I just shut off the cutting current. Next. Sometimes when you open the sternum, you find that the pericardium opens, and then you find the pericardial fluid everywhere. And then you think, oh God, what have I done? You just open into the pericardium. Nothing to worry. When does this happen? Next. Some of our patients may have a little bit more robust sternopericardial ligaments. These are normally found in the other animals, like the birds belonging to the Rates genus. So sometimes these get the pericardium into your saw, and then you end up opening the pericardium. But nothing to worry. You just have to make sure you get good hemostasis of the cut pericardial edges and just keep going. Next. So these are the guys who have a strong sternopericardial ligament. Next. So what are the deep structures that you can probably injure? So the trachea, the innominate vessels, the innominate artery, and the vein are the vessels which you should guard against. Sometimes you may, an over-enthusiastic cord-treated may, foray into these areas. You just have to recognize it, probably just complete hysterectomy, open it up, and then, take a few bites. Then I think you will be fine. Let's talk a little bit about cannulation. So you need an arterial inflow and you need a venous drainage. So normally we use the ascending aorta for putting in your arterial cannula. Previous. So I'll tap. So what size of a cannula would we like to use? The cannula must be small enough so you're comfortable. The cannula must not be too large, but it should be large enough for you to give good flows. So you do not have much of a gradient, and the perfusionist doesn't complain about high gradients and high pressures. So that is why you need to, for an adult surgeon, normally we would use a 24 size cannula when you have a good robust patient. If the BSA is lesser, then probably a 20 or a 22 cannula might be sufficient. How would you go about choosing exactly where you will cannulate? So I would advise you to go to the base of the innominate artery, slightly distally on the aorta. Okay, so just at the origin of the innominate, slightly to the left would be a good area to site the cannula. Before you fix that spot, it's good to palpate it to make sure it is free of calcium or atherosclerotic plaques. A lot of people would advise you to use a bicardial probe, a high frequency probe, to verify the ascending aorta, to study it, to make sure that you have a safe spot to put your cannula in, which is also a good way of doing it. But if we do not have a probe for any reason, we could gently palpate. The best time to palpate it would be to do it after you have inspected the vessels and the pressure actually has slightly dropped when you have looked at the heart. Then the aorta is a little bit more supple for you to palpate, and your palpation also would be more thorough because you can palpate it a little bit more easier. Okay, so you do that right at the beginning of surgery. You do not wait for a much later time. Okay, so before you get the conduits and all that, you decide where you will cannulate, how you go about. So study the aorta. Next. So normally I would use a two absorbable suture to go ahead with your purse string. A purse string is not circular. I would prefer a diamond shaped purse string because it's quicker to take. So you take two purse strings for the aorta. Both should be diamond shaped. Okay, next. So this is the first diamond that we have taken there. Next. Next. And this is the second purse string. So it's a diamond. What is the size of the purse string that you would take? It should be a little bit bigger, about a third bigger than the cannula that you're planning to put in. Okay, so if your cannula is that big, 130% of the cannula size should be a purse string, and your purse string should go 1/3, 2/3 depth into the aorta. So it goes just in the media of the aorta. Okay, so 1/3 out, 2/3 in. So 1/3 depth if it goes, it should be fine. So don't try to go right inside and it will bleed, you'll get a hematoma and then it becomes a mess. So just take a little bit more time, a little bit more patience to put your purse strings. They are so much more safer and so much more elegant. Okay, and now you decide to cannulate. You need to have a systolic BP of about 100-ish to cannulate, that is safer. And your ACT probably would be about 400 by this time. Next. So you make an incision with 11 blade. My preference is 11 blade. Some people also use a 15 blade. Some people even put a small side biter and then make a small opening and then hold both sides and then put a cannula. That's a little bit of an overkill. But you could stab insert, that is fine with me. And how much of a stab would you do? So that should be equal to the diameter of your cannula. So when you put it in, the diameter stretches to circumference, so it will be a little bit tight. Okay, so that much of tightness will be perfect. Next. And then once you DM, you connect your cannula. Next. Okay. Now, how do you go about your venous cannula? For most surgeries where you would operate on the left side of the heart, you don't need multiple cannulae. You can cannulate just the RA through the RA appendage using a two-stage cannula, and it will be perfectly fine to go and form. So all you need is one purse string in your RA appendage. Previous. Don't I? Can I get a slide over? This next is, it doesn't work. Okay, fine. So I tap and we move. I don't want to say next. Okay. Okay, so we sight the purse string on one side of the RA appendage. If you carefully watch the image in front of you, the purse string is on one side of the RA appendage. It's much more advantageous to do it this way. You do not want to make the entire RA appendage, no need. You do not want to make the RA appendage ischemic. So if you go around the RA appendage becomes ischemic, and it has got its own function. It has got its own endocrine function, its own chemosynthetic function. Why do you want to compromise that? So put your purse string on one side of the RA appendage, and through that you cannulate. Okay, so this is fine when you do an aortic valve, mitral valve, CABG, all this is fine. Whenever you need to open the right side of the heart, if you need to address the tricuspid, then you need to have two cannulae. Next. So this is a picture with the cannula in situ. Next. Okay, this is cannulated and ready to go. Next. Okay, so when you want to put two cannulae, you put the SVC cannulae through your RA appendage, and you have a separate purse string in the close to the IVC, probably a little bit lower than what is shown in this particular picture, and then you cannulate the IVC. If you go around the SVC and the IVC with, and then snug it, then you will go on total CPB. So you can open the RA without the problems of having the air in your cannula. Okay, next. So what are the different problems that can happen, and what are the things that you need to look for? The SA node is at the KO-atrial junction. It is a subepicardial node. It's fairly big. It's about 7 millimeters long in many people, maybe 3 to 4 millimeters wide. And it has got its own blood supply. The blood supply may come from either side or from both sides, from the right or from the circumflex. So it's better to be a little bit away from that. So how or when can you actually injure it? If your incision or if your meddling and holding goes anywhere close to the KO-atrial junction, then your SA node can get compromised. So it is always good to stay away from the KO-atrial junction. Okay, and your snugger, your SA node cannula, your SVC cannula, everything has to be away. Even if you put a direct SVC cannula, you will be far away from the KO-atrial junction. And if you put this one through, your snugger should be away from the KO-atrial junction. Your umbilical tape which you use to snug around the SVC cannula. Okay, next. The other place where you can have a little bit of trouble is where you try to put your cannula into the IVC. You have a large eustachian valve which kind of holds up your cannula and doesn't allow it to go into your IVC. Next. This shows the eustachian valve, an echo image which shows you the eustachian valve. Next. Sometimes you may have a large Chiari network which also would prevent your cannula from going in. So in such a thing, how do you get your cannula into the IVC? Take it gently out, maybe try a different route, different approach into the IVC. It probably would go in. Sometimes I find that if you close the sternal retractor a little bit and then try again, you succeed. So that should be fine. So what would you do if you don't succeed at all? Then you probably can't put your cannula into the IVC. You use a Ross basket and just drain the RA and you can go ahead with your CPB. Okay. Next. A few words on cardioplegia. Next. So if you want to give a root plegia, probably it's no problem. The pitfall that can happen with the root plegia, which I would like you to guard against, is that when you insert your cannula, it's got a still with a sharp tip. When you put it into the anterior wall of the aorta, don't go all the way down and stab the posterior wall. Then when you're coming off, you'll find that the posterior wall is bleeding, and then you have to dissect the aorta, turn it around and make sutures, and then it's not needed. Okay, so the best time to put in this cannula is when you are still not gone on pump. Okay, so when your heart is beating, your aorta is full, you put this cannula, snug it, make sure it's in the right place. Even if you have to do an aortotomy, keep this cannula there. Okay, no harm in that. Okay, don't put this cannula when you are when you are on pump. Okay, and when the aorta is softer. So put this cannula when you are on full pressures. Okay, so this is one thing that you have to guard against when you are doing a root plegia. When you have significant AR, then you give a direct ostial plegia. And when you're giving a direct ostial plegia, this is the sort of cannula that you would normally use. The angle cannula, which is obtuse angle, is probably for the left, and your right angle cannula is for your right. Okay, next. You could also give both the plegia together, and in that case, then the way you share it gets decided by the resistance of the tissue bed itself, and probably that is the best way to do this plegia. But otherwise, if you are giving it by yourself, you're deciding how much to give in the right or how much to give in the left. Your size of the coronaries will tell you. If you have an angiogram and if the right is big enough, you probably give 35-40% in the right and the rest in the left. If your right is very small, then probably 20% should suffice. If you don't have an angiogram, if your patient is young and if you've decided not to do an angiogram, then be judicious, have a look at the PDC, roughly where it's coming from, and then you decide. Okay, good. The angiogram which is playing on your screens now shows you two orifices. So when you have two orifices like this, you should not miss one orifice. So always it's important for you to see the orifice. Don't think that, okay, the orifice is there, I just saw one orifice, just put it through. Have a careful look around. Make sure that it is just that one orifice and it is just that one orifice only. Okay. So when you have two orifices like that, we use this sort of cannula. It's a little bit softer and smaller, and it would go right into your ostium. So it's a little bit nicer to have cannula like this. When you encounter this sort of a situation, this will definitely help you. Next. Okay, so this is a short left main. So when you put in a cannula into this short left main, it will selectively go into one of these cannulae. You would probably have seen that happening in the cath lab. And when they try to do an angio shoot, you find that only the circumflex fills or only the LAD fills, but it's only one ostium, and still you could selectively get into one of the two vessels. So in this sort of a thing, you have bulbous tipped quadriplegia cannula next, which would come in handy. So this sort of a guy would, would kind of oppose onto the aortic wall, and you could perfuse the left main, a short left main in its entirety, going with plegia going into both the LAD and the circumflex. Next. Retrograde plegia. Well, a lot of people are fond of retrograde plegia. Sometimes it's useful. Many people think that they should induce plegia with the retrograde and then give intermittent antegrade, especially in aortic valve surgery. So it's useful to know how to put in a retrograde cannula. So the first thing is something like this, and you would aim. So you would aim for the cannula to go towards the left shoulder of the patient. Next. You have self-inflating cannulas, you have cannulae where you can inflate the bulb and you can keep it in the coronary sinus. So the problem with the problems that could arise from this, apart from the cannulae not going in, the cannulae going somewhere else, and probably you traumatizing the coronary sinus, the other thing that could happen is you can probably be a bit far too in. If you're a bit far too in, the posterolateral veins get left out, and the protection to the right ventricle is not so good. So that is something which you need to guard against. So you need to be just inside the coronary sinus without traumatizing it, and you should be, of course, in the coronary sinus and not in the RA or in the tricuspid valve. Okay, so these are all the things that you need to guard against when you are putting this in. And to guide this, you can put your hand behind and you can feel the cannula in the coronary sinus. Next. So this is your retrograde plegia cannula. Next. Some of the other things that can happen when the cannulating is when you have a diseased aorta. To start with, I told you how you should palpate the aorta and you should assess the aorta and decide where you would cannulate the aorta. So your aortic atherosclerosis is to be evaluated using your epi-aortic scanning probe. If you have big plaques, try to avoid these plaques. So you site your cannula in a different place, you site your proximus in an appropriate place so that you don't get onto the plaques. If you just have about one area to put a proximal, you probably could do it without a side biter, with just an obturator. That's another nice way to do it. Okay. If you have a porcelain aorta, what do you do about it? Well, if you need to cannulate and cross clamp and open the aortic valve, you need to take a call whether you really need to go ahead with it, or maybe you should try alternative strategies like TAVI or So it all depends. I have seen people clamp a porcelain aorta and get away with it, but probably not advisable in the everyday situations where you might find a porcelain aorta. Your aorta can dissect if you are not careful. So when your aorta is bad, get your pressure down and do it. Okay, that way your safety margins becomes a little bit better for you. Okay, next. Phrenic nerve. Okay, phrenic nerve can be injured by cautery or ice rush, and this would give rise to not so good hemidiaphragm, and you can have post-operative lung problems. So you really want to preserve and protect the phrenic nerve. So both your phrenic nerves go by the side alongside the pericardial phrenic vessels. I think all of you would have seen the phrenic nerve. People would have shown it to you at surgery. So when you make your pericardial slits, when you open to that side of the pericardium, be very, very careful. Look at the phrenic nerve and stay away from the phrenic nerve. Next. I think the last point on a general, this general lecture would be to talk about the chest tube. So the chest tubes should probably be positioned away from grafts, away from the heart. Sometimes when the holes on the chest wall lie on top of the heart, you find that they could upgrade it, and I have seen people re-explore the patient for hemostasis because the tube was, upgrading the heart, the epicardium. So, and then, they just removed the chest tube and made do with the chest tubes in the pleural cavities alone, and the baby slowly got control. So this is something that you need to guard against. Sometimes the grafts may get sucked a little bit into the holes, and that will kink it, and a kinked graft will not have flow, and that gives rise to problems with ischemia, arrhythmias, RWMAs, and these anatomes and all that. So you need to guard against grafts getting sucked into these holes. Okay. I would now show you a few instruments. I have the Ross basket and the LB benders. So we talked about a scenario where we could not get into the where we could not get into the IVC. So when we couldn't get into the IVC at all, we would use this. So this is the Ross basket. It's got a small basket in the front. So all you need to do is just put this inside, and then you really don't need to get into the IVC. So this is something which should be there in all the almirahs next to the data. So in case you get into a problem, you could use a Ross basket. This is the nice mini olive-tipped cannula which I was talking about. So if you have a small coronary, this is very nice to get into the coronary. So we would like to use this. So this is the big tipped cannula, something which resembles your stethoscope eyepiece. So if you have a short left main and you do not want to selectively get into any of the coronaries, then you probably would use this. Okay, good. So this is your retrograde PJ cannula. This is a self-inflating one. So you would hold it like this, and you would insert it into the coronary sinus. Sometimes the assistant probably could do a better job inserting it from this position. Okay. The LV bent. Okay. So sometimes you're doing an aortic valve and you don't need to do a mitral valve at that time. So you should know how exactly you would insert a LV bent. So you pre-bend it like this. Okay, it comes straight. Okay, and then you You always pre-bend it like this, so that when you insert it into the pulmonary vein, it gets into the mitral. Okay, across the mitral into the LV. So it's actually a LV vent. Okay. And sometimes if you are not able to get it across into the LV, just let it be in the lane. It still would work. Don't push it around here and there. I've seen this vent perforate any number of chambers in the heart. So it's not a good idea to push it. You need to be very, very gentle in sliding it into the left ventricle. Okay. So I think we've kind of finished a few of the pitfalls that can happen when you open, set up things to go and come to do your valve surgeries. I think now we will get into the actual mitral valve replacement. Okay. Can we have the next PowerPoint, please? We put the camera back there. Okay, so we will now talk a little bit about the pitfalls in mitral valve replacement. I'll try to show you something also on a wet lab. Okay, next. So the mitral valve and the tricuspid valve in a nice little preparation here for you. It's been illuminated so you could understand the various aspects of its morphology. Every year we run a cardiac morphology course where we come up with things like this which aid in a better understanding and in a good comprehension of the cardiac morphology, so it would be a good spine for you to build your own skills and your own surgeries around. So I would encourage you, it's a July affair, cardiac morphology. So I would encourage all of you to take part in that every year. And every year we try to come up with something new. So this is from one of our cardiac morphology sessions. Next. Okay, so when you look at the mitral valve, this is a view from the surgeon's position. So you refer to the different portions of the two leaflets thus. Okay, you say A1, A2, A3. It is in the same way as you write in the English language. So A1, A2, A3, P1, P2, P3. Okay, next. When the anesthetist has a look at it, okay, the anesthetist is a very, very important part of cardiac surgery and the performance in the theater, especially for valve surgeries. So if they do not guide you with the extra eye that they have, the extra eye is the eye which is in the esophagus of the patient. They sometimes push it into the stomach as well. Okay, so this would see it right, left, alter. So a surgeon's view is thus, and an anesthetist's view is the reverse of that. So you should know that. So whenever you look down, you know that it's A1, A2, A3. Whenever you look there, it is A3, A2, A1. Okay, so as long as you know that, you'll be fine. So it's like taking a selfie. It's very simple. So the kids, I'm sure all of you will manage it very well. So it's not like looking at it in a mirror. It is like taking a selfie. Okay, next. Okay, so the relationship of the bundle to the mitral valve, it's at 2 o'clock position. Okay, so this picture is there to show you where the bundle is. Next. Okay, so this is a picture which should be in all of our minds. Okay, this is a picture of the base of the heart where it shows us the relationships of all the valves. The aortic valve is obviously related to all the valves. So now we look at this picture from the mitral valve perspective. So if you look at the mitral valve, you see the AML above, you see the PML below. The AML is about 1/3, the PML is 2/3. The AML is slung between the two fibrous trigones. Okay, or you can say the central fibrous body and the left fibrous trigone. So the central fibrous body is what is related to the aortic valve, the tricuspid valve, and the mitral valve. Okay, and in that region you have your membranous septum, and the bundle goes through the membranous septum. So that membranous septum and the bundle is at the 10 o'clock position of how the surgeon looks at the mitral valve. It is related to the aortic valve at the NCC RCC commissure. It is also related to the septal valve of the tricuspid at the septal anterior anteroseptal commissure. Okay, so this is something which you should clearly understand. Okay, good. Now the aorta. Where is the aorta in reference to the mitral valve? It's somewhere around the 10 o'clock position, which means the middle of that will be the 10 o'clock position, and the aorta is a big structure. Okay, so the aorta is there, and the left and the non-coronary cusps of the aorta are related to the mitral valve. So the aortomitral continuity is there. So when you look at the mitral valve through the aortic valve, you would be seeing the AML curtain getting slung between the LCC, NCC area. Okay, so if you go across that, as in your hook winding procedures, you go across your NCC, LCC commission, you go into your AML as in your Marujan procedure. So that's where the continuity is. Okay, good. So aorta and mitral valve are related thus, so that you should know very clearly. So along the PML, what are the other important structures that go through? So the coronary sinus, that goes around the bottom of the mitral valve. So around the 6 o'clock sinus, 6 o'clock position is coronary sinus. The circumflex artery also goes around. It probably goes slightly away from the coronary sinus. There's a higher chance of you getting the coronaries, getting the circ when you are operating on the LA appendage. So it goes around the LA appendage at the base of the appendage and curves all the way around. So that circ goes around the PML area. This coronary sinus also goes around. I'll show you these things there. Next. So this is how the surgeon looks at the mitral valve. Here you find the mitral valve working, but this is one other stunt from the cardiac morphology session to show you how the valve works. Next. So how do you, when you have exposed and when you have looked at the mitral valve, what do you do? The first thing is you need to know how to identify the annulus. Okay, so that is an important thing. So the annulus is seen as a pale ring. Okay, sometimes when a little bit of blood or cardiac media solution is on the leaflet, it delineates that area a little bit. So that is one way in which people teach you, that is how you know where the annulus is. But if you really want to know it for sure, that is the annulus, hold the AML, move it up and down, where it is hinged onto the heart, that is where the annulus is. Maybe just outside that. And you can pass a little right angle underneath that and you can get to that. So probably we go and have a look at the wet lab and see if we can identify an annulus, and then let's see what we can do. Okay. Okay, so we have set up a mitral valve here. This is the AML, and this is the PML. This is the anteromedial commissure, and away from the papillary muscles, anteromedial papillary muscle, and the posteromedial papillary muscle is there. and that is the posteromedial commissure. So now, if you hold the amel like this and move it, you know that that is the area where it is hinged. So that would be the annulus. So it's pale white. If you pass a right angle underneath, that is the maximum area that you can get into. So now you know where the annulus is. Okay. So you can see that little fellow moving there. Okay, so that would be the annulus. Okay, good. So if you need to cut it, right, so you hold it up. Okay. So you make a small incision on the amel like that. Okay. And then you can excise it with your scissors. So this is a valve with the AML excised and the PML preserved. So that's the normal way in which we do a partial caudal preservation. Sometimes this portion of the AML can be sutured onto the sides, this portion onto these sides, so you can get a total caudal preservation. There are different ways in which a total caudal preservation has been described. So you could use any one of those things if you so wish to do a total caudal preservation. So now the next thing is you start taking your sutures. So there are different ways in which you can take sutures. Normally what you do is you hold it and then you take your suture about down. Okay. So when you do that, okay, when you do this, you get your pledget on the atrial side. So this is probably the commonest way in which people would be, putting your suture. So this is a suture with the pledget on the LA side. Okay, and then once you put the valve in there, so you take sutures, pledgeted sutures all around, and then you take sutures on the valve annulus, and that is how you put it in. Okay, the same thing sometimes you can put the pledget on the ventricular side. So this is pledget. A lot of people believe that this is probably a stronger way to do it, or a more robust way to do it. So when you do this, your pledget would be on the ventricular side, and only the plain sutures would be coming out like this. Okay. In case you need to recite or you need to revise these things, you should be very careful to take the pledget from the inside, because otherwise the pledget will fall into the left ventricle, and that could embolize into areas where you don't want it to continue. Okay. One of the ways of doing a mitral is to put a continuous, especially if you have a healthy annulus. So I thought I would show you a suture where we would do a continuous suturing. Okay. So normally what we do for that is you take You take a pledge it, put it in the middle, and then you start on the 6 o'clock position. Okay. So once you do this, then you get your valve. So what valve is this? This is the ATS valve, isn't it? Good. So it's one of the nice valves that we like to put in the mitral position, or for that matter, any position. So yeah. Okay. So you position the valve close to the valve. Okay, your prosthesis is close to the valve, and then you start taking a few bites like that. Okay. So you take a few sutures on both sides before we lower it. Okay. So we lower it like this. Once we lower it, okay, you use a nerve hook to tighten your sutures. Unfortunately, we didn't bring the nerve hook to the wet area, so we would do it with this. Okay. Okay, so once you get these sutures like this, get rid of the holder. Okay. Some people like to push it into the LV and keep suturing it and keep bringing it up as they go. I like to keep it in the LA and do the same thing. Okay.
need to be mindful of the annulus, the size of the annulus. Even though you may have sized it and put a valve of the appropriate size, you need to tailor your suture such a way that you finish up the annulus exactly over the valve. Now here, if you see, it looks like we may get a huge paravalvular leak, isn't it? So when do you get a paravalvular leak? When you're putting a valve? Okay, many reasons. One, if you leave a lip, if you do not suture it well. Two, if you do not size your valve properly, and that makes you end up with not being able to suture properly. The other is if you have a lot of calcium or a diseased valve, the native annulus may not conform around your sewing ring. So in such a situation, you may end up having a paravalvular leak. Okay. So supposing I don't close this properly, then you'll have a paravalvular leak here. Okay. So that would be a paravalvular leak in the 11-11-30 position. Now I do not want that. So I'm taking an extra effort to make sure that I actually close it absolutely perfectly. Okay. So this last stitch is something which is, you may have to take through and through the annulus, and it would be a difficult stitch, especially when you're doing mix. We use a continuous sutures even when we're doing mix. So this last stitch, if you are not very happy with this last stitch, you can take one threaded stitch here and then bury the knot onto the side of that. Okay, so this pledget in the 6 o'clock position, and then this is how you keep it. And once you do that, you make sure that nothing interferes in the free movement of your leaflets. Okay, so there's a nice little valve tester that they've given us. So I would encourage you to use the same valve tester and not any of the instruments from the instrument tray. Okay, use a very soft little valve tester to do this. Make sure that your movement of both leaflets is absolutely free. So this is in an anti-anatomic position because you find that the two leaflets are on either side like this, as opposed to AML, PML up and down. If you rotate the valve and keep it the other way, that would make it come into an anatomic position. Okay, good. Let's go back to the presentation. Keep the second session ready. Okay, so do you guys like continuous suture? How many of you use the continuous suture? How many of you use interrupted sutures for mitral? Please share in the comments, and we would be interested to know. I hope a lot of you will, start using more of continuous sutures. It's so much easier. You can finish it up in 4-5 minutes. It cuts down on your timing, especially if you use bioprosthetic valve. You just push it in, go to part observation, just sew it in blankets and get out. And in an ischemic sick heart, it's a lot something to have handy. Okay, good. So. So I told you the anesthetist forms a very important part of guiding us. And they are the people with 3 eyes, like the God Shiva. They open that eye when needed, and they see much more of the things. And when you are in sync with them, they use that eye to help you. And it's very important to be in sync with them. So let us see what Dr. Sujata has to tell us now. She will show us a little bit about how perfect and what
Greetings from Madras Conditions. Am I audible?
Yep, audio fine.
Okay, greetings from Madras Condition. I am Mr. Senior Consultant Cardiac Anesthetist. This we are going to discuss about the echo aspect of processing the prosthetic valves, prosthetic heart valves, both mitral and aortic, and the pitfalls again, mitral and aortic valves. The echo of single building disc mitral valve mechanical mitral valve processes. You can see the valve moving, opening and closing, and we could see a major orifice and a minor orifice, and the center is moving. So the next thing I would like to show the color flow across within this. You'll see the major orifice and a minor orifice, and the washing jet. You can see through the major orifice and washing jet in the center. Usually, you see a washing jet in the center of the electronic valve, and the washing jet through the major orifice. You will see that in the major orifice and the central part of the valve. So this is again another type of treating this valve, which is opening and closing. You will see the normal intravalvular washing jet, which is washing jet is normally is a protective thing to see. Is normally a protective thing to avoid thrombosis and prosthetic valve thrombosis. This is a 3D echo of a bileaflet mechanical valve in which we will see both the leaflets moving, and there is a central narrow orifice and two lateral orifices which are bigger, and we will see both the leaflets closing and opening. This is the color flow across the bileaflet mechanical valve, in which you will see the washing jets in the hinge points. This is another type of single tilting disc valve, opening and closing with a major orifice showing washing jet, and the washing jets, when we apply color, we will see the washing jets through the valve. This is another picture of the echo of my bileaflet mechanical valve. Both the leaflets moving well just before coming off bypass. There is latent motion of one of the leaflets. Once they fill up the LV and heart starts ejecting, the leaflets will be synchronously moving well, and there will be wide range of movement. So usually when we just before coming off bypass, in this echo we see a lot of air in the LA and the LV, and then both the leaflets moving well. And sometimes you come across one leaflet not moving well, and the full range of movement is not seen. But usually when we fill up the heart and heart starts ejecting, the leaflets start moving well. So the color, plain color for the prosthetic valve, we usually see whether there is any intravalvular leak or paravalvular leak or if there is any abnormal movement of this leaflet, the leaflet is getting stuck or the leaflet is not moving well. These things we assess by putting the color and assess the if there any micro revegetation or erratic revegetation. In this, we are also assessing the biotic path. See, when you assess prosthetic hardware, whether it is mitral or aortic, you have to assess postoperatively the other valves also, other valves function, which I will show some of the echo videos where the and after replacing aortic valve, mitral valve showing mitral regurgitation or replacing mitral valve, aortic valve showing aortic regurgitation. These are some surgical complications. So always bear in mind to look into the other valves after coming out like us. So this we are seeing the aortic valve also. Aortic valve is normal, tricuspid valve is normal, and some Doppler parameters we remember when you assess a mitral valve prosthesis. So this is the basic few parameters to be remembered are the peak velocity. If it's usually less than 1.9 meters per second, and the mean gradient across the mitral valve is normally less than 1.5 millimeters normally. And if it is above 5 and above 10 millimeters, it is considered significant stenosis. Any values between 5 to 10 is moderate stenosis. So again, we assess the effective orifice area. I will be talking about effective orifice area again and again because that plays an important role in assessing the patient prosthesis mismatch. This patient prosthesis, you have to assess the patient prosthesis mismatch for all patients who undergo valve replacement because it determines the long-term outcome of the patient, the mobility and mortality of the patient. So the effective orifice area is usually calculated by continuity equation. You calculate the stroke volume by the echo parameters, and then you divide by the prosthetic valve, whichever valve you are. Exactly, we are coming. Whether it is aortic or mitral valve, you have to divide the stroke volume by calculating the continuity equation and the VTI across the mitral valve or the aortic valve. You will get the effective orifice area. Then you index it to the body surface area of the patient. See, even if you have a normal effective orifice area, if the BSA is more, the same valve with the same size valve, the BSA is high. When you index, you can see the gradients increase. So you have to select the appropriate size of valve according to the body surface area and index it. Again, the other important parameter we see in echo is the Doppler velocity index. We see the LVOT VTA and the if it is a mitral valve VTA. If it is aortic valve VTA. So you have to divide the LVOT VTA by aortic valve VTA for aortic prosthesis or mitral valve VTA by LVOT VTA for mitral prosthesis. And you get a value. Say you should remember that the mitral valve prosthesis with VTI, the Doppler velocity index display or velocity ratio, all these things are all same. So if it should be less than 2 for mitral and it should be more than 0.3 for aortic. So these are basic things should be remembered as an echocardiographer. We should know that these values play an important role in assessing the reason for problems coming up bypass, whether it is a patient prosthesis mismatch, whether there is obstruction in the flow or hyperdynamic state, high flow through the valve. These values play an important role in differentiating the cause for the high flow gradients across the valve. So for mitral valve, the index effective orifice area should be more than 1.2 centimeter square per meter square. So this is I'm just showing the echo of a normal patient, normal bileaflet mechanical mitral valve implanted patient, in which we assess the gradient across the mitral valve. It is 3 millimeters mercury. Normally it should be less than 5, so it is normal. So next is we have to assess the LVOT cross section area and the LVOT VTA to calculate the effective orifice area. Then, as I have already mentioned, this is the formula how we calculate the effective orifice area and the Doppler velocity index or velocity ratio. Doppler velocity index velocity ratio All these things are all the same. So in this patient, we assess the LVOT VTI, microvalve VTI, ESA is 1.5. Then we calculate the index defective orifice area. It came to be 1.3. So normal is it should be more than 1.2. So this patient's index defective orifice area is in the normal range. Again, the Doppler velocity index or velocity ratio is again less than 2.2. It is 0.8. So this is normal. So after any mechanical or any bioprosthetic or mechanical valve, we should see the gradient across the valve, the intravalvular, paravalvular, and deflect motion. These are basic things.
So continuing on with the surgical aspect of the mitral, I told you initially about the sternotomy. Sternotomy for a mitral valve should be slightly to the right, so that we will be able to see the mitral, especially the small LA better. What are the different incisions which people would, which a surgeon would use to approach the mitral valve? Next, the incisions on the heart. The common way we approach the mitral valve is through the left atrium. So what we do is we dissect into the Waterston's groove. So the Waterston's groove is that groove which you see pulmonary veins on that side, is SVC, IVC on this side. Okay, so SVC, RA, IVC that way, and your pulmonary veins or LA on the other side in between. That's the Waterston's groove. So you dissect in the Waterston's groove, you get into that interatrial plane of Sondergaard. So you need to dissect a little bit so that when you make an incision on the LA, it is a little bit more anterior than at the line of vision, what you would have seen initially. So once you dissect the LA, the RA of the LA a bit, then you can enter into the LA at a more suitable area. Okay, next. So that is the normal incision. So you can enter into the RA and across the septum, and you can use an intratrial septal view of the mitral as well. Okay, especially if you don't want to open the LA, you're doing a tricuspid and a mitral, you can just open the RA to the tricuspid, open the intratrial septum to the mitral and get out. Then you can do it that way. Okay, so you open the RA in its body. See how the incision is away from the KO-atrial junction. So this is how you open it. Next. So you inside the interatrial septum now. Okay, so here next. That so across the interatrial septum, you can look at the mitral valve. It will be just there. Okay, it will be very close to you. So you could the view through an LA and through an interatrial septum is slightly different. Sometimes you can go onto the roof, extend the incision onto the roof as it is seen here. One of the things that you should clearly note here is that the aortic valve and its non-coronary cusp is very much related to the interatrial septum. So especially in an echo that I'm going to show you, the interatrial septum will go bang on it onto the non-coronary cusp. That is one of the ways in which you recognize your non-coronary cusp. Next. So if you look at this, this is the torus aorticus, or the aortic mound which you see on when you're looking at the interatrial septum. So that is where the aorta is related to the interatrial septum. So sometimes when you suture the interatrial, your incision on the interatrial septum, you're likely to pick up the aortic valve, the non-coronary cusp of the aortic valve, and then you end up having a lot of air. So that is something which you need to guard against. Next. Okay. So now what are the things that you can go wrong when you are exercising the valve, debriding the valve? Okay. So normally I told you to exercise the AM and try and preserve the AM. Okay. So when you're exercising the valve, if you foray into the aortic annulus, then you know that you're in trouble. Okay. So that you should not do.
when you are cutting the cord in, okay, you cut at the tip of the papillary muscles, okay. Do not pull up and cut the papillary muscle. Then in that case, what would happen is you are likely to tent up the left ventricle and sometimes open to the exterior out of the LV wall. That is something which we do not want. Okay, so do not try to cut the papillary muscle off. Let the papillary muscle be inside. Even if you have a little bigger papillary muscle, that will probably never interfere in your valve. Okay, so at the papillary muscle tip is where you cut your cord. Okay, next. Sometimes the valve is full of calcium. Next. So how would you excise this? How would you decalcify? If the calcium is predominantly in the leaflet, then you're lucky. You just need to get rid of the leaflet. So you excise it just at the annulus, calcium comes out. If your annulus is calcified, that is when you have to carefully decalcify. And your decalcification also has to be thorough. So you use a roger to decalcify. A roger is an instrument with a big jaw, and you go chewing on the calcium, so it kind of extrudes the calcium out of the tissues. You do not cut it out, okay? You make it extrude the calcium out of the tissues, so only the calcium and the thicker part comes out, and some fibrotic stuff is left behind for you to suture your valve onto. Okay, so that is the way in which you decalcify. So this decalcification has to be thorough, because sometimes that little bit of calcium or spicules of calcium that might get left behind may interfere with the apposition between the sewing ring and the native annulus, and you can have a paravalvular leak in that area. So you do not want that to happen. Okay. So one of the reasons why you can have a paravalvular leak is when you have improperly excised calcium spicules and improper apposition between your valve annulus and your sewing ring of the prosthesis. Next. You also need to be careful with your little bits of calcium. You don't let them be free, lie around free in there, because you know, they can embolize where you don't want them to embolize. Okay, next. Okay, so what are the different ways in which you can get a paravalvular leak? This is something we need to guard against. You do not want a paravalvular leak. You can compromise on your hemodynamics, you can compromise on everything, infections, so many things. Okay, so you need to seal the valve perfectly and do it well. A paravalvular leak can come if you leave a small bit of lip on the when you're suturing. So you do not suture all the portions of the annulus onto your sewing ring. There is a bit of a lip or a deficiency left out. You can have a paravalvular leak. Sometimes I told you the calcium spicule may prevent proper apposition. So these are all reasons why you should be very, very careful. Mostly the paravalvular leak can be picked up in a post-op echo. Very rarely you can get this paravalvular leak later on, which means something has happened, something has moved, given way, or you didn't suture properly onto the annulus, or something gave way. So especially in a scenario of infected endocarditis, where you know the tissues are not all that healthy, so you need to make sure a good healthy part of the tissue is actually sutured onto the annulus, onto the sewing ring, so that you do not get paravalvular leak. So this is one of the guys who had a tuberculous endocarditis, and the whole man was rocking. So you find that the almost 180 degrees of the valve is rocking, and you know we had to take a lot of extra pericardial sutures to, plated sutures to make sure that we repair this. Next. One of the other ways. So how do you tackle a paravalvular leak? Okay. So the first step in tackling a paravalvular leak is to identify where the leak is. Identify that that alone is the leak and that there are no more leaks, and take some extra sutures to make sure that it is secure. Okay. One of the ways to address it, probably if you find it late and you're not there to actually take an extra suture, is to put in a small device and close it. So this is a video of device closure of paravalvular leak. Next. This shows you a plugged paravalvular leak.
Okay, next. So that's another way of, closing a parallel leak, and it's good to have it in your armamentarium of your hospital. So caudal preservation. So I told you, PML, you can just preserve the entire PML. It's a good way to preserve and papillary continuity. If you want to do a total caudal preservation, if you use a bioprosthetic valve, you can just put it into the valve and just suture it off. You really don't need to do anything else. If you want to, translocate the AML, you can cut it into 2 bits or even multiple bits, and you can use small sutures to put it onto your commissures, and then to implant the valve. So what trouble can a caudal preservation give you? If a lot of stuff has been preserved and they are there in the subvalvular area, they may interfere with your valve movements, okay? Especially if it is a bileaflet valve. If it's a mechanical prosthesis, the preserved bulky chordae may interfere in your valve movements, and they may restrict your valve movements, and sometimes they may even be stuck. So that is something which you need to guard against. So you need to carefully check whether your leaflet motion is free of interference from the preserved chordae. Next. The circumflex. The circumflex goes very closely around the mitral valve. We saw that in the pictures depicting the anatomy. So we should not compromise on the coronary sinus on the circumflex. It is quite possible to compromise the flow in the circumflex artery. Many people would think that it's so far away, how am I going to take a bite from that? But you never know. So the areas where you can hit the coronary are when you are addressing the LA appendage, as the coronary goes at the base of the LA appendage, and also around the PML. So these are 2 areas where you should be very, very cautious about your bites, and you should not get the coronary. It may be something as trivial as having a little turbulence in the coronary flow, which the anesthetists may pick up, or it may be something horrendous as having a total regional motion abnormality, and it does not help you come off. So these are all things that you should be guarding against. Next. LA appendage obliteration. Sometimes the LA appendage may be very friable, so you have to be very, very cautious about it. Some people would like to, put a silk tie around the LA appendage at the back. So it is at that time that you have to be a lot more cautious about not traumatizing the friable LA appendage. And of course, I told you about the circumflex artery. The other thing is about how you handle the clot which you have taken out of the LA appendage. So you need to take the clot out in its entirety, and you need to throw it away, not leave bits of it in the left side of the heart. From there, it may embolize to areas that you don't want it to embolize. Next. Okay, now the orientation of the mitral valve. Okay, so when I showed you the bileaflet valve, the ATS valve which we implanted in the mitral position, it was anti-anatomical. So it opened this way, like this. We can always also have it like this and open this way, which is a more anatomical position. The orientation is more so, or rather was more so important when we use tilting disc valve. A very beautiful article has been written about orientation of the valve by Professor Antius, and we should all read that. Okay, so if you next. So to orient a valve, you orient the larger orifice of a tilting disc valve towards the AML, so in an anatomic position. So a tilting disc valve is normally preferably oriented with its larger orifice towards the AML side. Next. Okay, so the other problem that can happen with orientating your valve is when you end up using, especially in a smaller patient, a pediatric patient, where you may use an aortic valve in a mitral position. Okay, normally nobody does that, but if you end up having to use, say, a 23 valve and you do not have a mitral 23, you take an aortic ventricle, always remember you need to flip the valve. Okay, so you need to implant it in like how a mitral valve is supposed to be oriented. If you do it the other way around, upside down valve, then when you're coming off, you find that you have no cardiac output. So that is something which you need to guard against if you use an aortic valve in a mitral position. Okay, good. Now let's talk a little bit about leaflet restriction. Okay, so when your leaflets are restricted, what do you think of? As you are coming off, the heart may be underfilled. So, the walls may restrict the movements of the leaflets. So, once you fill the heart nicely, the valve starts moving well. Okay, so you see this very often in the mitral. Okay, once the heart is full and you have come off and still the valve movements are not good, then there is something wrong. Okay, then you need to think about whether there is any tissue underneath which may be obstructing it. Sometimes if you put your pledgets on the left ventricle side, some tissue may have come inside, or your caudal preservation tissues may be, obstructing free movement of your leaflets, or sometimes some malplaced suture or some suture which may not have been pulled properly. So these are all the various possibilities that should run through your mind when you are when you encounter a leaflet which is not moving as well as you would like it to move. Okay, next. Okay. So now we will have a look at a few of the echo pictures of these pitfalls and these problems which we may encounter. We put in a mechanical bioprosthesis in a mitral position. Over to Rafika.
The pitfalls of following a mechanical mitral valve implantation. Mostly after a mechanical or a bioprosthetic mitral valve implantation, there are complications of prosthetic valve. So they are immediate complications and complications. Complications are paravalvularly stuck occluders, NVOT obstruction, mitral regurgitation following mitral valve replacement, mitral regurgitation following aortic valve replacement. Patient processes mismatch and low cardiac output states. So the late complications will be the structural valve deterioration, transformation, thrombosis or thromboembolism, paravalvular regurgitation, patient processes mismatch, and hemolysis, cardiac failure. Pseudoaneurysm formation and infective endocarditis. So, risk factors for paravalvular leak. So, there are many risk factors like annular calcification, tissue friability, prior endocarditis, corticosteroid therapy, and type of valve, whether we use a mechanical valve or a bioprosthetic valve, the surgical techniques, continuous sutures not to develop paravalvular leaks than the interrupted sutures. The common site of mitral valve, mitral paravalvular leaks, usually they are in the anterolateral and posteromedial segments. So usually there is no uniform distribution of collagen fibers in the annulus. So mostly you see the paravalvular leak in the posterior part of the annulus. Like, because the collagen fibers are less in the posterior part of the annulus. So when you address a paravalvular leak, when you have to look at a paravalvular leak and tell the surgeon where the paravalvular leak is, you usually orient it to the clockwise direction. You flip the aortic valve, keep the aortic valve in the 12 o'clock position and say that the paravalvular leak is in the what position, like 2 o'clock position, 10 o'clock position, in the clockwise direction. So this picture shows mechanical bilateral mechanical valve with the aorta plate anteriorly and the relation of the paravalvular leak to the surgeon's point of view, surgical view. So, like these, there are different types of paravalvular leaks, which you will see a split-like defect and round or oval-shaped defect, or it can be a slow tunnel-shaped defect, crescent-shaped defect. Again, the best way of detecting paravalvular leak is by the echocardiogram, especially by 3D echo. It makes the surgeon easy to locate the paravalvular leak, and usually we address it in the clock position, whether it is in the which part of the valve, whether it is in the posterior, anterior, or it is 2 o'clock, 3 o'clock position. We address them accordingly. Usually, it is difficult for the surgeon to see during the surgery, and 3D especially helps in locating the site of the paravalvular leak. Again, when there is a paravalvular leak, the echocardiographic some variable, some parameters should be remembered to assess the severity of the paravalvular leak, whether it is mild, moderate, or severe. So usually, by 2D echo, we see the vena contracta. If the vena contracta is less than 3 millimeters, it is considered mild paravalvular leak, and if it is more than 7 severe, and any numbers between mild to severe will be moderate paravalvular leak. Again, 3D echo helps us to locate the paravalvular leak and also to assess the quantify the degree of paravalvular leak, especially the vena contracta again less than 3 millimeters or more than 7 millimeters, and effective regurgitant orifice area. The effective regurgitant orifice area will tell us the severity of the paravalvular leak. So this is a picture in which we see the single tilting disc with a restricted movement, and when we apply the continuous wave Doppler across the valve, see that the gradient is increased across the mitral valve prosthesis. Normally, as earlier discussed, the mitral valve prosthesis gradient across the mitral valve prosthesis will be 8 millimeters, less than 5 millimeters per this patient, it was around 8 millimeters per So, there is a significant gradient across the prosthetic valve. This is again one of the leaflet is not complete because of the planus, and there is a turbulence across the prosthetic valve. Again, there is a restricted disc leaflet movement causing increased gradient across the valve. Again, in this echo, we will see abnormal washing jet. Usually, you will see the intravalvular leak when the valve leaflets are opening and closing. In this, there is a because of the valve leaflet dysfunction, the intravalvular leak was more. So, in this patient, the valve was removed and replaced with another valve. Again, in this echo, we will see a clot sitting on the mitral valve prosthesis, and restricting its movement. So, as Dr. Jacob has already mentioned, during caudal preservation or when you exercise the posterior papillary, when you are cutting the caudate connected to the posterior papillary muscle, the papillary muscle will be wobbling in the cavity, and very rarely the possibility of interfering with the leaflet movement. In this echo, we could see the posterior papillary muscle is just hanging in the rectangular cavity. But this patient didn't have any issues with the valve leaflet movement, just for the purpose I'm showing this echo. So there's a picture of a normal bioprosthetic valve, 3D view of a normal bioprosthetic valve with the current flow through the bioprosthetic valve. So when you see, as I see a bioprosthetic valve, you see the leaflet movements and the flow across the valve, and if there is any paravalvular leak. So over to Dr. Jacob to speak about the bioprosthetic mitral valve, a normal bioprosthetic mitral valve implantation.
Shall we start? This one. Can you handle it? Okay. I think it will pick up. Don't worry.
So, okay, so this is a bioprosthetic valve which we are planning to implant in the mitral position. Okay, so when we do this, I've taken a few sutures here. So we take the first sutures near a strut to go into the 6 o'clock position. Okay, so that is how we orientate a bioprosthetic valve. Okay, so this strut needs to go into the 6 o'clock position. As we do that, the other two struts would go into the 10 o'clock and 2 o'clock positions, thereby not interfering with the aortic LVOT area. Okay, so that is how we do it. And when you place the valve inside, there is something that I want to show you that you have to very clearly look at. See, this loose leaflet, it may go on the thread. One of these loops, which you see here, is very likely to get onto a strut like this. Okay, so if that happens, okay, so if you get that, it will interfere in the movement of two. Are you able to show that? Okay, put it across. Yeah. Okay. Measures. Okay, so if the thread goes on to the there, you can see that. Yeah, good. So if the thread goes on to a strut, then we will have interference of two of these leaflets moving. Okay, so that is something which you need to avoid. See there, can you see? So the thread should not go around the strut like that. That's a very important thing that I want you to look at. Okay, good. So this. Now I'd like to show you something about the orientation. So I told you the 6 o'clock, it should be oriented 6 o'clock, a strut on the 6 o'clock position. Okay. Now, if for any reason you mal-oriented it, okay, you will see that there is a strut which is coming on into the LVOT. See, can you see a strut gets into the LVOT? So if you rotate it in the right way, the strut goes away. There is no strut. If your mal-rotated valve, you get that strut poking into the LVOT and you will get an LVOT turbulence. Okay, so that is something which you need to avoid as well. So one strut in the 6 o'clock position will ensure the other two struts will be in the 10 o'clock and 2 o'clock, thereby being free, keeping the LVOT free. And a wrongly placed strut would, a wrongly placed valve, mal-oriented valve would get you one strut into the LVOT like so, which is something which you want to avoid. Please. Yeah. Okay, so this is what I was trying to tell you. One strut at the 6 o'clock position ensures two struts at the 10 and 2 o'clock position, which will keep the LVOT free. Okay, you see the iota there. The LVOT is below that. Okay, good. So if you mal-rotate it and get a strut into the LVOT, then that would give you some turbulence of the LVOT, and that is something which we do not want. And Dr. Sujata will show you that this is a possibility as well. Okay. So the other thing which I illustrated was when you put in a bioprosthesis, you should be very careful that the thread does not go over the strut. Sometimes if the thread goes over the strut, then it will restrict the movement of two leaflets. So you will have an abnormal intravalvular leak, and also two leaflets not moving very well, being restricted in its movement. If there is a stitch which you take through one leaflet, then that would give rise to an abnormal leak in the intravalvular leak, and one leaflet being restricted in its movement with two leaflets moving fine. Okay, so that means you've taken a stitch through one of the leaflets. Sometimes the needle may injure a leaflet and it may tear, and in that situation, you will have an abnormal intravalvular leak with the torn bits of the leaflet flapping around in the wind. Okay, good. So Dr. Sujata will now show you a few of the echo pictures of all these things that can go wrong with the bioprosthesis. Over to Dr. Sujata.
Who plays the net? Nobody knows that are same way. paravalvular leaks leading across the valves and any issues with the post-bypass area. So in this video, we will see the paravalvular leaks, we will see the mitral valve and the tricuspid valve. We could see the paravalvular leak in this picture. We could see a paravalvular leak like a bioprosthetic valve implantation in the posterior area. So again, there is a paravalvular leak in the 10 o'clock position. As I have already mentioned, we rotate the lead. We acquire the rotate the average valve in the 10 o'clock position, and the arrows shown here locates the two paravalvular leak at 2 o'clock position. Again, this other view demonstrating the paravalvular leak. When you see the LA and LV and the paravalvular leak is going into the LA. Another echo in which there after the bioprosthetic valve implantation, we could see a mild paravalvular leak. Again, when you see a paravalvular leak, we have to assess the position and also the inner contractum, the width of the jet. Depending on the width of the jet, we can decide whether it is a very mild paravalvular leak, moderate or severe paravalvular leak. So this is a 3D echo in which we could see the prosthetic mitral valve, bioprosthetic mitral valve with the restricted movement of left coronary cusp and the right coronary, the non-coronary cusp. Seeing the other pictures, we could see that the vegetative suture going through the base of the NCC and LCC, causing the valve motion restriction in the aortic valve. Leaflet movement, there was some restriction in the movement. And this was causing severe aortic regurgitation, which we could see in the other views. In the 2D pictures and the 3D pictures, I show you the aortic regurgitation following the mitral valve replacement. You can see the NCC and NCC restricted movement, leaflet movements. This patient, there was aortic regurgitation and following the bioprosthetic mitral valve replacement. So the AR was almost moderate to severe aortic regurgitation. So this is another case in which we could see the aortic regurgitation following bioprosthetic mitral valve replacement because of perforation through the leaflets through the non-coronary cusp and left coronary cusp causing severe AR. So this is another echo of patient in which this is a long-term complication in which the bioprosthetic valve was degenerated and torn, causing mitral regurgitation in this patient. So there is severe mitral regurgitation. You can see the leak through the valve, and the other immediate pitfalls following bioprosthetic valve implant, mitral valve implant is the leaflet movement, the restricted leaflet movements. So you will see one of the leaflet not moving. This is from the atrial view. We could see one leaflet not moving, and the same picture when it is flipped up the other side, and if you see from the ventricular aspect, we will see the restricted leaflet movement of the bioprosthetic, one of the leaflet not moving. So this is another echo in which we could see a turbulent flow across the bioprosthetic valve, and we apply a colored continuous wave Doppler across the valve. We could see the increased gradient. If we remember, the normal gradient across the mitral valve prosthesis should be less than 5. Here it is, mean gradient is around 10 millimeters mercury, which shows that there is severe stenosis. So just to revise the echo Doppler parameters, basically it is the mean gradient, the peak velocity. When you see a peak velocity of more than 1.9, then you should look for the Doppler velocity index. That is VTA, LVOT, VTA, mitral valve VTA by the LVOT VTA. There is an algorithm in which you can assess whether there is because there is a problem in the prosthesis or there is a problem or the patient is in a hyperdynamic state. So you have to index it to the patient's body surface area, and based upon that you calculate the effective orifice area of the patient. So this is the algorithm in which if you see a increased gradient across the mitral valve prosthesis, whether it is mechanical or prosthetic valve. So just go through this algorithm. If the effective orifice area is similar to the reference range and the index effective, then you index it. If the index effective orifice area is less than 1.2, then it is patient prosthesis mismatch. If it is more than, if it's normal or more than 1.2, then you have to look for the Doppler velocity index, that is velocity ratio. If it is less than 2.2, again it is within the normal range. That is the time where you look for the velocity ratio. Velocity ratio, when the high gradient velocity ratio is normal, then it might be due to high flow across the valve. If there is velocity ratio again being normal and the pressure half time, now you look for the pressure half time. If the pressure half time is more than 130 milliseconds, then there is some obstruction in the prosthesis. If it is variable or pressure time is variable and again the velocity ratio is abnormal, then you consider there is some technical error. This is an algorithm which is easier to know whether there is patient prosthesis mismatch or there is a problem in the valve leaflet, there is obstruction in the valve leaflet to assess in the post-operative period and to whether to address the problem. Over to Dr. Jeter to talk about the ionic valve.
Next. So I think you guys enjoyed the little presentation about the mitral valve. We addressed a lot of pitfalls, and Dr. Sujata was kind enough to show all those things on the echo as well. So some of the things which I do not want you to forget is that, when you put in a valve, the aortic valve is close by and you can, get that. Sometimes when you're doing a double valve, you'll be looking at some of these sutures from the aortic side as well. So it's all possible. Okay. So now let's look at the aortic valve replacement, and what we would, what can go wrong. So back to your base of the heart diagram. Okay, this is a very, very important diagram, as I already told you. And look at the whole thing from the aortic perspective. So when you look at the aortic valve, look at how the mitral valve is related to the aortic valve, the aortomitral continuity, the aortomitral, how the AML curtain hangs off the LCC, RCC, how the membranous septum and the bundle is related to the RCC. The bundle penetrates somewhere close to the RCC, LCC, I'm sorry, RCC, NCC commissure area. and the pulmonary valve actually is a little higher than the aortic valve, so it's really not next to it. So these are all the things that should be permanently part of you as a cardiac surgeon. Okay. This is one of the famous articles written by Dr. Anup Sood, and he has depicted all the relations of the aortic valve. So what is within the aortic valve is actually below or at a lower level, and what is outside the aortic valve here shown is what is related to it on the outside. Okay, so this is what it is. So you have a kind of a naked area where the LCC is, that's where it is an epicardium. The left atrium is related to the LCC, HCC area. The interatrial septum goes bang onto the middle of the non-coronary cusp. The right atrium is related to its that half of it which is related more to the RCC. The RVOT will be related to the RCC area. So that is how it goes around. And on the inside, you find the membranous area is related to the RCC, NCC commission area. Okay. So this is a dissected specimen where the base of the heart is shown with all the relationships that we have just now talked about. This is an aortic valve, a picture of the aortic valve. And this once again is an open door aortic valve where we talk about the relationships. So the RCC and CC commission area is shown in to be related to the central fibrous body and to the membranous septum. The NCC left coronary cusp area being related to the left fibrous triangle, and across that is hangs the mitral curtain. Okay, so this is the same thing as a line diagram for you. Okay. And this is one of the big videos from a cardiac morphology session, July affair, as I told you, where you see a moving aortic valve, how it opens and closes. The three nodules of Arrantii at the middle coming together at the end of diastole. Okay. This is an illustration which shows us the aortomitral relationship, how the aortomitral area works. Okay. Okay. So this is the aorta. You can see, can you show the corona aortus? Okay, a little bit of fat. Yeah, so that is the corona aortus. A little bit of fat is present on the ascending aorta, which is like a little cross. Okay, so that is the corona aortus. The fat pad which is seen below that, that would be the RCA fat pad. Okay, so that gives us an indication of where the RCA would come off. That is usually within the fat pad and about 3 or 4 millimeters below it. Okay, so these are all the things that you need to know about the ascending aorta. This is the cannulated ascending aorta. You have a right atrial cannula which is pulling down the fat on the epicardium, which actually was kind of covering the RCA fat pad. Here you can see the RCA fat pad a little bit more clearer. Just can you point of the RCA? Yeah, so that is the RCA fat pad. So a little about your aortic incision should be a few millimeters above the RCA fat pad. Okay, good. So you identify the RCA fat pad, and about 7 millimeters above that would be a nice area to do your aortotomy. If you put your aortotomy lower down, you have a risk of injuring the right coronary artery. If you don't injure the right coronary artery, still, when you take your sutures, you can be too close or you could be inside the right coronary artery. So this is another way you may injure the right coronary artery. So you need to make sure you leave enough area or enough place to place your sutures when you're closing the aortotomy. Okay, so this is also an important thing. If you make your iototomy too high, then you will struggle. Your vision may not be all that good, and your sutures will have to be taken far away. So you need to be sufficiently low so that you're comfortable, but not too close to your right coronary artery. Sometimes you make an incision at the level of the corona aortus. When do you do that? You do that when you put in a sutureless valve. When you put in a valve which is stented, and you just have to put 3 sutures to anchor it, and then you can balloon inflate it into position. When you do that, especially you could do that via a mix, you open at the corona aortus because you need that much of an aortic cylinder to implant your, to place your aortic stent. Okay. And whenever you open in a patient with a small aortic root, always open in such a way that your incision can be extended into the NCC commissure, or however you're planning to do your root widening procedure. Okay, so that is how you. So it has to be. It is not something which is parallel to the aortic annulus all the way. It is something which could be extended into widening the aorta always. Okay, good. Now, once you open, you place some little stay sutures to expose your aortic valve. Now you need to excise your aortic valve before you implant your aortic valve. Okay, so how do you go about your excision? All excisions may not be as neat and clean as the specimen display. You will have to take it out in bits and pieces, sometimes piecemeal. Okay, so you need to excise all of it and leave just enough annulus to place your sutures on it. So when you excise too less, you may not be able to place a sufficiently large valve in there. Okay, so that is not a great idea. So you need to be able to excise sufficiently so that you place as big a valve as you would like to. If you excise too much, or if you injure the aortic valve during excision, that again is you need to guard against that. Some people put a stitch on the suture and then they pull it to to excise the aorta, to excise the aortic valve. If you overdo that, you may sometimes incise the aortic wall from the inside. So then you end up closing it with a fire, and then that might compromise a little bit of your precious aortic space. Okay. In a case of a calcific aortic stenosis, how do you decalcify? That is a very, very important step. Okay. So if the calcium is in the leaflet and you have a space, those bits can be anyway excised. Those bits of calcium which are in continuity with the annulus, those are the ones you need to look at very, very carefully and decalcify in a very careful manner. You use a ronger for decalcification. The ronger has big wide jaws, and you need to extrude the calcium out of that rather than aiming to cut and take out chunks of it. Okay, so you chew it, extrude the calcium out, try to keep or retain a little bit of the fibrous tissue intact. Okay, so that is a very nice way of decalcifying it. At the aortomitral continuity, you need to be very, very cautious about your decalcification. This is an area where you can injure the AML. Okay, so you should not. So from the mitral valve, you are careful about the aortic valve. From the aortic valve, you need to be careful about the mitral valve. So we do not wish that you injure the AML. And even when you take the sutures, you should not include the AML in your sutures and thereby causing mitral regurgitation. Okay, so these are things that you need to be very careful about. And whatever calcium you debride, those calcium has to be very carefully removed. If bits of it end up lying here and there in the left side of the heart, they may embolize to the brain or into the coronary artery and give you trouble. So this is something which you do not want. When you excise the valve or when you decalcify, be very careful of the area of your LCC, right coronary, non-coronary junction. Okay, this is the bundle area, and we do not want you chewing around too much there, which may compromise on the bundle integrity. Then you come off in junctional, your cardiac output is a bit low, especially when you have hypertrophied LV. You really need that atrial kick and a coordinated atrial kick in that. So it's not all that great to injure the bundle, especially in a sicker patient. So be very, very careful about the bundle area and try to be very gentle. And many times, even if a bundle block is transient, you'll be able to get away without a pacemaker. Okay, AML injury, we talked about that. Okay, so now when you're implanting an aortic valve, how do you orient your valve? How do you orient a tilting disc valve? So again, we go to the famous Professor Antune's paper. So if you look at this, you have oriented the valve, a tilting disc valve, so that at a fully opened position, it is not parallel to the axis of the aorta. If it is parallel to the axis of the aorta, when diastole starts and you need to close the aortic valve, it would be lazy and you would get a regurgitant jet into the LV, which is something you do not want. If you have oriented it in such a way that there is an angle between the opened leaflet and the axis of the aorta, the closure is efficient and your regurgitant volume that is needed to close the valve is negligible and you really do not have any AR. Okay, so that is something which is very important. And how do you achieve that? You achieve that by orientating your larger orifice towards the left coronary posture. So then you achieve this by doing this. Okay, so that is how you need to do that. So a tilting disc valve, we hardly use tilting disc valves these days, but whenever you do that, you need to orient it with a larger orifice closer to the left coronary, not because you want a lot of blood to flow into that, but because you want the valve to close early in diastole. Okay. Okay. Now, if it's a bileaflet valve, how do you orientate a bileaflet valve? A bileaflet valve, you would need to. It actually doesn't matter how you orientate your bileaflet valve, but I would like to have one orifice close to the left coronary and kind of, it just makes me feel happy, that's all. Okay, whichever way you orientate a bileaflet valve, it's going to work very much fine. There are some valves which are supposed to rotate itself into a good hemodynamically and optimal position by itself. Many of these leaflets which hang off a groove inside the valve, they don't seem to work all that well. So be very, very careful about self-orientating valves, and that is something which I would like to warn about as well. Okay, good. When you place a valve, a bileaflet valve inside, there is a little housing on which the leaflet is hinged. So we do not want that housing to kind of strut over the annulus and kind of project out. It needs to go right within the annulus and right inside the valve so that the opposition between your aortic native annulus and your sewing ring is perfect. Otherwise, in that area, you will get a bit of a parallel leak, and sometimes the valve leaflets also may get restricted. So we do not want that. Okay. So a bileaflet valve can be, even though oriented anyway, you look for the housing to be well seated, and you do not want any portions of the valve to be above the annulus. Okay. Bioprosthesis.
Now, how do you orient a bioprosthesis in an aortic valve? Very much similar to the native aortic valve. So there are three struts in your bioprosthesis, and the struts should correspond to your commissures. So commissures to strut, it should be fine. So as long as you have a tricuspid aortic valve, your commissure to strut, three leaflets correlating beautifully with your aortic valve is all fine. But what if you have a bicuspid aortic valve? A bicuspid aortic valve, how do you orientate your three strut bioprosthesis in a bicuspid aortic valve? Well, what do you want to avoid? What problem do you want to avoid? And why do you need to orientate it so well? The problem that you want to avoid is your strut getting in the way of your coronary perfusion. Okay, so you want to make your coronary to be away from a larger strut area where the perfusion may not be all that great. So that is what you aim for. So you place your valve inside and see how to place it. You rotate and see so that your two coronaries are nice and free in your bicuspid aortic valve. So in that optimal position, if you place your three strut bioprosthesis, that would be fine. So you need to rely on your own common sense to do that. You need to have optimal coronary flow. You do not want any of these struts to interfere with your coronary flow. So that is what you need to look at. Okay, so I think this would tell us how to orient the valve in an aortic position. For completion's sake, the one other thing that I would like to mention here is sometimes in a very large aorta, people might want to put in a larger valve and they might use a mitral valve in an aortic position. So they need to remember to flip it. So if you do not flip the mitral valve when you are putting it in an aortic position, you will end up having a wrongly placed valve, and that would mean the leaflets would just hang down, and when you're coming off, your LV would just distend like hell. So it would distend to smithereens. So that is something that we do not want to happen. So one needs to be very cautious if you so decide to use a valve, a mitral valve in an aortic position. Okay, so now let's look at a few of these things on the wet lab. Okay. Okay, so this is the aorta. This is your fat pad, which I told you about. Okay, so this is your fat pad. So just those 5 to 7 millimeters above is where you open your aorta. Okay, so you incise it a little bit like this. Okay, just wait for the last 50 ml of media. Okay, so just as the last few drops are going in, not few drops, just when the last bit of cardioplegia is going in, if you make this incision, it's on a full aorta, so it's a little bit easier and happier for us. Okay, so we would open that way. Okay, so you look inside and see how far away from the annulus you are, and accordingly you make further incision. So when you open this bit, you need to be able to get into the non-coronary or your non-coronary left coronary commissure if needed. So this bit has to go down like that. Okay. So especially if you need to do a root widening. Okay. So yeah. So that is how you go it. Okay. So if you decide to go here, this would be a mix if you cut across here. Okay. If you go a little farther down and decide to cut across the commission, okay, then that would be a luminous procedure. Okay, so that would mean that you will get on to the AML. Okay, so the AML is there. Okay, so that's this is your AML. Okay, so the AML is slung between your, are you able to see that? Okay, try to get the bill to. Yeah, that's good. Okay, so that's your AML where the blue pointer is, and that is slung between the non-coronary and left coronary. And in your root widening, if you open across here, open, okay, across the furniture, you're into the AML. Okay, so your patch needs to come from this AML to widen the coronary. Okay, now this is the leaflet. Let's excise one leaflet and let's take a few sutures. Okay, so I'll show you some of the different techniques in which you could take these sutures. So normally one takes pledgeted sutures. Okay, so one would hold the annulus a bit and take your suture above down. Okay, take a suture like that. Plain suture also. One more pledgeted. Okay, so this is a suture where the pledget has been placed on the aortic side, and this is what it looks like. Okay. Okay. Now let us place a suture pledget on the LV side. Okay. So you can contrast both side by side. So here you have the pledget on the LV side. Okay. So this is a suture with pledget on the LV side. This is a suture with the pledget on the aortic side. Okay. So these are two different ways of implanting the valve. If you don't have much space, one of the other things that you could do is to take simple sutures. Okay, so a simple suture is taken above down on the aortic annulus and below up on the aortic valve. Okay, so this is a simple suture. Okay. So that is a simple suture. I'll also show you a figure of 8 suture. Okay. So okay, so let's take a figure of 8 suture on this. Okay, so you take suture, above down, no pledges, and above down again. Okay, so you take sutures, above down, above down. So you end up having 2 sutures and 2 needles. Okay, so 2 sutures and 2 needles which you put through the suturing annulus. Okay, so this is a figure of 8 suture. So you will have 2 sutures to put through your valve annulus. So this is a figure of 8. This is one where you have your pledget in the aortic side. Okay. This is one where you have the pledget on the ventricular side. Can you see that? Pledgets on both sides. And this is a simple suture. Okay, so a simple suture. Okay, so simple suture, pledgets on left ventricle, pledgets on the aortic side, and a figure of 8 suture. Sometimes one other way of doing it, which I would like to show you. Sometimes you can take a stitch from the outside of the aorta. Okay, from the outside of the aorta inside, and then anchor it there. So your pledget will be on the outside of the aorta. Okay, so you can suture that way. Okay, so you take a stitch from the outside. So it comes onto the annulus. So you will find that there are 2 stitches for you to put your valve in, and the pledget is on the outside. Okay, so that is another way in which you can save some space as well, when the space is very precious. Okay, good. And in this area, when you suture, you should be very careful that you do not involve the AML. The AML is just there. Okay, so AML is just there. So you look at the AML and be there, and you do not injure the AML or take sutures on the AML. If you take the AML like that and if you suture it there, then that would make sure that there is a mitral leak. Okay, so that is something which you have to avoid. See, can you see AML? So avoid the AML. Okay, good.
This is a 3D report showing the bilateral mechanical aerobic position. See the 2 leaflets opening and closing, the minor orifice and the orifice in the center, and 2 orifices reflect this. The opening angle. This is the current flow of the mitral valve. Flow across the mitral valve. There is no paravalvular leak or any abnormal regurgitation through the mechanical mitral valve processes. This is the mechanical mitral valve. CPV, when assessing the valve, we see the movement of the leaflets and explain you can see the aortic valve and the mitral valve. Both the leaflets in the aortic position, the mechanical valve moving well, and the mitral leaflets, the anterior mitral leaflet and the posterior mitral leaflet talking well. Seeing the color flow across the aortic and the mitral valves, there is no aortic regurgitation or mitral regurgitation. The deep transgastric fluid, we see the aortic valve, there is laminar flow through the prosthesis, and there is no regurgitation or any paravalvular leak. So then we have to assess the, as mentioned earlier, we have to assess the gradient across the aortic valve. So this is how you assess the LVOT PTI, that is the velocity time across the LVOT, and also you have to assess the aortic valve PTI. So aortic valve PTI is usually assessed by continuous wave Doppler, the LVOT PTI by applying the pulse wave Doppler. So in this, the normal mean gradient across the aortic valve should be less than 20. So it is only 6 millimeters mercury within the normal range. So again, we have to assess the patient processes mismatch by assessing the LVOT PTI, aortic valve PTI, and then the stroke volume. Stroke volume, as already mentioned, we assess by the calculating equation, and we also we have to calculate the LVOT cross section area. So by seeing the and also these values are required in PSA valve size, and the valve size was 19 millimeters valve, and we used by PSA for the patient was 1.6. The indexed effective orifice area calculating with this parameters, it was about 1.23. So the normal effective orifice area, anything less than 0.8 centimeter square per meter square in aortic position is considered as a patient prosthesis mismatch, and if it is less than 0.6, it is definitely severe patient prosthesis mismatch. So this is how we assess my aortic valve, and we should never forget to look into the mitral valve. Also by assessing the aortic valve, either it is mechanical or bioprosthetic valve. First we see the gradients across the valve, intravalvularly, paravalvularly, and then leaflet motion. And then we see the bioprosthetic valve, implantation in aortic position. Over to
Yes, can we have thank you. Thanks, Dr. Sujata. Thank you for the breakfast session. Sharing a few fluoroscopy runs. This is a tilting disc valve. This is the upper one is in the aortic position, the lower one is in the mitral position, and they're moving reasonably well. Okay. This is the old star inverse valve. You find the poppet in place, and that is opening and closing. And this is in the mitral position.
The mitral valve had four pillars or pores. The aortic valve has three. So that's one way of saying that this is the mitral position. That this is the mitral valve, and of course the orientation and the position as well. This is a bileaflet valve, opening and closing very well. So one of the ways in which you assess leaflet motion is by fluoroscopy. So what are the different problems that you may encounter by when you place a aortic valve? So when can you get a parallel leak? So if you should not have a parallel leak, you need to place an ideal sized prosthesis in place with perfect apposition of the native tissues to the sewing ring. So there is no place where it could leak from. Okay, so an ideal valve, an ideal sized valve with a good pliable soft tissues everywhere, which is perfectly opposed onto the sewing ring. Okay, so when this is not perfect, you can have a parallel leak. If there is a lip, if there is some area where it is distracted by something which is hard and the apposition is not good, you can have a parallel leak. So when can it be distracted by something which is solid and prevents perfect apposition? When you have some calcium left behind and that does not allow good apposition, so you can have a parallel leak in that area, which is why we want to have a nice debridement of calcium in the annulus. One other thing that can distract is the housing. If the housing is not seated perfectly within the annulus, the housing is above, then you would not have probably have seen the sutures may not have been properly tightened and the housing will be kind of strutting it up, and through that area you can have a parallel leak. So that again you should be very careful. So you should carefully inspect every aspect of your sewing ring and make sure it is well seated and this nice soft tissue is in perfect apposition to that. Okay, so parallel leak. Leaflet movement can be restricted, especially if you take pledgets on the LV side. Some of these tissues, if they are not properly trimmed, can get into the area of the leaflet movement and it can obstruct your leaflets. If it hinders it a little bit, then you have restricted movement. If it is quite a bit into the orifice, then your valve will get stuck in some position, mostly in a closed position, sometimes even in an open position. So a leaflet which is stuck in a closed position would be, giving you high gradients, and a leaflet which is stuck in an open position would be giving you regurgitant jets. So that's how you make out what exactly is happening. Of course, you can view it as well. MR. So like how we discussed AR in the mitral implantation, you need to talk about MR in an aortic implantation. So if you get, if you harm the AML, if you injure the AML anyway, you can get a mitral regurgitant jet. If the AML is injured during valve excision, maybe you just made a little nick on the aortic, on the anterior mitral leaflet, or the needle kind of nicked it, then you can have a small hole in the AML through which you can have MR. If you deprived a bit of calcium on the AML and then you kind of yanked it a bit and then you had some injury to the AML, still you can have a MR through the leaflet. Sometimes if you take sutures on the AML, like how I showed you, then the AML will get restricted and kind of tethered back. and you can have a leak. The MR jet will be within the valve and not through the AML. Okay. So MR can happen because of these two mechanisms. Okay, one is an intra-leaflet MR, the other one is a proper MR in between the leaflets. The other thing that can happen is your coronary can get compromised. So how does the coronary get compromised? If the coronary is a bit too close to the annulus, or if your valve is a bit too close to the coronary. So you should have sufficient space between your sewing ring and the coronary, or your struts and the coronary, so that the coronary flow is not compromised. If you oversize a valve, if you try to put in a too much larger valve than what the thing would hold without opening your
Code Pink Pediatric General Ward. Code Pink Pediatric General Ward. Code Pink Pediatric General Ward.
if we put too large a valve, then we could compromise on the coronary because it can get stretched sometimes. So these are the different mechanisms in which coronary flow can get compromised. If the flow is just about compromised, we may still get away. But if the flow is compromised quite a bit, you can have problems like your RV may not move well, your inferior wall, if your RCA is compromised, if your left is compromised, you may have abnormal ventricular fibrillations or RWMA. So these things are to be avoided. Okay. I think we will now look at a few echoes and see how these problems can be picked up by the anesthetist. Soumya, camera.
Jacob has explained the problems in implanting aortic valve prosthesis, includes the pitfalls in aortic valve prosthesis. I will show you a few echo pictures where we have landed up in problems following mechanical aortic valve prosthesis in mind. This echo see following mechanical valve implantation in aortic position, see a significant aortic regurgitation because of the restricted movement of the leaflet. So another view we could see in the post bypass, there was a significant aortic regurgitation. There was also a paravalvular leak, as mentioned earlier. It was under tenopro position near the non-coronary cusp. The non-coronary cusp position. A mild paravalvular leak was seen in another view near the RCC position, the same patient. And the other pictures showed there was profuse intravalvular and paravalvular leak. And assessing the gradient of putting a continuous wave Doppler across the valve showed an increased gradient across the valve. It was around the gradient about 55 millimeters mercury. So the normal cutoff value should be mean gradient should be less than 20 millimeters mercury. So this patient had significant transvalvular gradient, mean gradient being 55 millimeters mercury. And the other patient, as Jacob already mentioned, that when we are suturing the bioprosthetic valve or the needle can pass through the anterior mitral leaflet or in the base of the anterior mitral leaflet, causing mitral regurgitation. This is an echo showing the incorporated anterior mitral leaflet. You could see the mitral regurgitation through the anterior mitral leaflet. there was a perforation in the anterior mitral inlet, and the patient has a MR perforated inlet. So this is about the pitfalls in mechanical aortic valve replacement. See this perforation or including the suture through the anterior mitral inlet can occur with the biprosthetic valve also. And things we have to look is the intravalvular leak, again paravalvular leak, leaflet movement restriction, and flow through the coronaries. Whether it is normal or there is any regional wall motion of that times. Dr. Jacob, we talk about biprosthetic valve implantation in aortic position.
Okay. So now we'll talk a little bit about the bioprosthesis in an aortic position. So one is the orientation. Like how I told you, the three struts should correspond to the three commissures. The problem comes when you do not have three commissures. When you have a bicuspid aortic valve or a unicuspid aortic valve, then what do? Then in such cases, you need to orient it in such a way that the coronary will come in the interstrut area, thereby having good coronary flow. The bioprosthesis should be of sufficient size. Bioprosthesis have a higher gradient for a given size compared to a mechanical valve. So you need to be aware of this, and you should try to put in a sufficient size bioprosthesis for the given patient's BSI. A bioprosthesis will eventually degenerate, and when that happens, if you can have TAVI-friendly size, it would be good. A TAVI-friendly valve, it would be good, and you could avoid a second surgery at that time for the patient. This shows you the three struts. The patient with the double valve, patient has bioprosthesis in aortic and then mitral positions. Okay. So now Dr. Sujata will tell us a little bit about the bioprosthesis.
We continue the echo session of the assessment of aortic bioprosthetic valve. As I said earlier, any valve, bioprosthetic or mechanical valve, the assessment is similar. Just I'm going to show the echo pictures of a bioprosthetic aortic valve and the complications following aortic valve implantation. This is as Dr. Jacob mentioned, following the aortic valve replacement, you should always assess the mitral valve also, not only the aortic valve. This patient will see severe MR because following the bioprosthetic aortic valve implantation. This was because of the AML restriction. The AML suture going through the base of the AML restricting the complication with the posterior mitral inlet, causing severe MR. So then the other problems with the aortic valve replacement, the assessment risk factor assessment for systolic anterior motion of the mitral valve causing mitral regurgitation. So for example, the risk factors for systolic anterior motion of the mitral valve will be assessing you have to when the patient has a hypertrophy, left ventricular hypertrophy, ventricular septal hypertrophy. Then the risk factor, especially when the PML is more than 15 millimeters or the AML is more than 27 millimeters and the AML-PML ratio is less than 1.3 and the distance between the coaptation point, that is the C7, we call it as C7, distance between the coaptation point of the mitral valve to the interventricular septum is less than 2.5 centimeter or 25 millimeters, or the angle between the aortic and mitral valve angular plane is between less than 120 degree, or if there is a small ventricle, or the interventricular septum is interventricular septal thickness is more than 1.5 centimeters, then there is a risk of developing postoperative systolic anterior motion of the mitral valve, causing severe turbulence and the echo. So what we can see in this echo is there is a preoperative. This is a preoperative echo. You see a mild MR in this patient. And there is some turbulent flow across the FUOB. So we measured the basal septal thickness. It was around 1.7. The normal cutoff value for assessing the risk is 1.5. It was more than 1.5. Okay. The C-set distance, as mentioned earlier, the distance between the coaptation point of the mitral valve when after they are popping to the interventricular septum. If the C-set distance is less than 2.5, this is again 2.3. So this patient had a narrow LVOT. So there was all risk factors for developing postoperative SAM. So this patient, after the coming of bypass, the postoperative period, there was significant MR because of the non-copting minor defects. So this patient developed moderate to severe MR, and we checked whether there was any disturbance in the left main coronary or the left circumflex. There was no any flow disturbance in the coronaries. Then we we changed the inotropes with the noradrenaline, the and filling up the heart, increasing the preload, the MR reduced. This is a classical example of SAM following the aortic valve replacement. And we have to keep in mind the patient has the septal hypertrophy or narrow LVOT, small LV cavity, or the C-set distance is less than 2.5. The development of SAM should be kept in mind, and make sure that it quickly maintain the preload and reduce the contractility of the arm, reduce inotropes, and try to come up with noradrenaline. So in this patient, you will see the MR significantly coming down. So again, patient processes mismatch. It's very common. Moderate PPM is more common in aortic position than in the mitral valve position. It's about 20 to 70% moderate PPM. Severe PPM is the patient process. Effective index effective orifice area is less than 0.6 centimeter square per meter square. So severe PPM, the incidence, reported incidence is about 2 to 11%. So to remember, to revise again the dorsal velocity index or velocity ratio, mitral valve, it should be less than 2.2 or more than 0.3. If it is more than 2.2 or less than 0.3, there is patient processes mismatch, and there is some flow across the, there is increased gradient across the prosthetic valve. This is an example to show that even if you have a same mitral valve, same size mitral valve with the same effective one, for example, valve effective orifice area of 1.3, the VSA is increasing from has to be based upon the effective orifice area should be indexed with the body surface area to calculate the pressure gradient. This is an algorithm again to make us easier to assess the reason for it. The elevated jet velocity across the ionic band. When you assess, when you measure the gradients either prosthetic or a mechanical band, and you see the contour of the jet contour tracing is parabolic, then it says there is some obstruction through the valve. It is triangular, it is a normal flow. So if it is, then you have to assess the diastolic, the Doppler velocity index. So as I said, it should be more than 0.3. In this algorithm, you can see if it is more than 0.3 and the acceleration time is more than 100 milliseconds, then you consider there is significant stenosis and there is some stenosis with subvalvular narrowing. Or if it is less than 100, normal prosthesis, and you have to index related to this area, and if it is with the acceleration time is more and the effective index effective this area is also less. When you think about patient processes mismatch. So this is a easier algorithm, easy to remember, in which you just see the high pressure gradient across the prosthetic valve, either aortic or prosthetic valve. Then you see the calculate the effective orifice area. Then you index it. See, when you index it, the effective orifice area, if it is less than 0.85 in aortic and less than 1.2 in mitral, then mild to moderate patient processes mismatch. If it is less than 0.65 in aortic and less than 0.9 in mitral, it is severe PPM. So then comes the assessment of you have to see the velocity index on Doppler velocity index to know about the other reasons for even if the index effective orifice area is normal range, but the gradients across the valve is high, then it could be due to a high flow rate or a technique. So this is a easier algorithm to remember and to assess the prosthetic valve, either in the aortic or in the mitral position. So coming to conclusion about assessing the prosthetic valves, either mechanical or bioprosthetic valves. The class 1 indication is the recent indication is recommended under prosthesis implantation 6 weeks to 3 months for the assessment of valve hemodynamics. D is indicated at any point of time whether the patient develops signs or symptoms of prosthetic valve dysfunction. So class 2A indication is the annual TE should be done in bioprosthetic valve patient after 10 years, even in the absence of any change in clinical status. So this is an important thing to remember, that we have to do a TE right, the patient doesn't have any symptoms after 10 years in a bioprosthetic valve. This is class 2 indication. Thank you. Over to Dr. Jacob.
Thank you. Can we have the next presentation? Next. Next, we'll do the next one. I'll take a look at it. Hope you guys are liking this program. We definitely are enjoying ourselves here in the Triple M studios, and we enjoy teaching. There is a beautiful saying in Sanskrit: more than the calf yearns to suckle the mother's milk, the mother loves to give the milk to the calf. So that in the same tone, we here in Triple M, we love to teach, and this is something which is a passion of our hospital, and we take great pride in teaching
and in furthering the knowledge, in sharing our knowledge, and in furthering the specialty. So we hope that you also are enjoying listening to this and being part of this program. Thank you for being with us. I think we will go to the next, in continuation with what Dr. Sujata told us. She was talking a lot about patient prosthesis mismatch. She was talking a lot about how we should put in an adequate sized valve. But for the surgeon, sometimes you're crippled because you do not have big enough annulus or a big enough or room enough to put in what the anesthetist wants you to put in. But somehow, you know, with root widening techniques, you need to be able to accommodate as big a valve as you can. So what is this patient prosthesis mismatch that she was talking about? The word was coined by, or the term was coined by Dr. Rahimtullah in 1978, as early as 1978. Mismatch can be considered to be present when the effective valve area after insertion is less than that of a normal human valve. So inherent to this concept is that a smaller than expected orifice area in relation to the patient's body surface area will result in higher transvalvular gradient. So you get higher TPGs if you have less EOA for a given BSA. Okay, and that is related directly to the flow across the valve. In fact, to the second power of flow across the valve, and it is inversely related to the area, inversely related to the second part of the effective orifice area. Thereby, we get the equation TPG is equal to Q squared by EOA squared, the constant being in the denominator. Okay. If you assume a cardiac index of 3 liters per minute per meter squared, if you implant a valve with an effective orifice area of 1.3 centimeters squared in a patient with a BSA of 1.5 meters square, you will have a TPG of about 13 mm mercury. The mean TPG will theoretically be 35 if your BSA becomes 2.5. So in a larger patient, you get a higher gradient for the same valve, for the same setting. So you need to, so it's important to, to think about the patient size as well. So this tells you the relationship. As the BSA keeps increasing, the TPG gets increasing. If your cardiac output increases, again, your mean pressure your TPG will increase. Like if you're an active patient, if you're doing some activity, then the flow across the valve is more and the gradients will become more. Okay, so these are things that you need to know about. So what is the parameter used to define a mismatch? So what you do is you index EOA on BSA, okay? And if you get 0.85 centimeter square for meter square, then that means that is ppm. So it's moderate ppm if it is between 0.65 and 0.85, and if it is less than 0.65, it is a severe ppm. Okay, so and it's not all that rare. It seems to be pretty encountered every now and then. So you need to try to avoid giving a patient prosthetic mismatch to your patient. So you need to have a sufficient valve area. So if you look at this, as the valve size keeps getting smaller, the mean gradient keeps getting higher, and below a certain thing, it's probably unacceptable. And why is it unacceptable? A lot of studies have been done. It will be mass regression, or systolic function, or improvement of the NOHA class, freedom from cardiac failure, freedom from cardiac events, mortality. Everything seems to have a bearing. Seems to be related to a sufficiently large prosthesis. So if you replace your native disease with a prosthetic disease, try to keep the prosthetic disease to a minimum. Try to put in as big a valve as is possible so that your EOA is large enough and the patient would be less symptomatic, would benefit from the surgery, have a good LV mass regression, and have a better NYSA class, and have in essence a better freedom from mortality. Okay, so these are some different valves, different sizes, and how they correlate with the body surface area in terms of effective orifice areas. Okay, so for a smaller valve, for a smaller BSA, you need to put sufficiently larger valve. Even a small valve would cause a patient processes mismatch. Okay. This is how you measure aortic diameters. So your diameter at the annulus, your diameter at the sinus of valsalva, at the sinotubular junction, and the ascending aorta. So the valve is seated at the annulus. So it's the annular dimensions that you need to look at to decide what valve you're going to place. And how exactly are you going to measure this? Okay, the first view is actually mid-esophageal short axis view across at the AV at the aortic valve level. The other one is at the aortic valve level short axis view. So when you measure it exactly in the middle, it would be actually slightly smaller than when you measure the so-called larger diameter. So if you go into the sinuses and measure, you will actually get a slightly larger size. But eventually the size would be something evened out between the two, because once you put it in and once you tie it, it kind of opens out a little bit. So you need to choose a valve which is just about right for you, so that you don't have to put a larger valve and then compromise on coronary and things like that. Okay. This is the famous equation of Poisson. The flow across an area depends on the fourth power of the radius, the pressure gradient across that place, the viscosity, and the length of the tube through which the blood has to go through. Okay, and the most important feature of this equation is the radius and the fact that it has been raised to the fourth power. So it is that much important to have a good radius through which you need a fluid to pass at sufficient speed or sufficient quantity. Okay, so when you double the length, it increases your flow increases. If you double the length, it increases by a certain amount. If you double the pressure, it increases by 4 times. But if you double the radius, it increases by to the power 4, which is much higher than what you would get when you increase your pressure or your viscosity. So a 19% increase in radius will double your volume rate. So it is actually less than 1/5. So all you need to get is just a less than 1/5 increase in radius in your size of the valve to double your volume rate. So there is a huge difference between putting in a 19 valve and a 21 valve. So if you can put in a 21 valve, it is so much better than putting in a 19 valve. So that's what this one tells you. A small amount of arterial occlusion can have a surprisingly large effect. So a 20% reduction in the in your radius gives you so much of reduction. 60% reduction, 50% reduction almost to 90%, and an 80% reduction almost to 99%. So a 19% reduction in radius will halve your volume rate. 1/5 down, your volume rate goes down to half. 20% goes down to 40%. So radius. Very important to put in a large valve. Okay, so this is to tell you about a little bit to dramatize the R4 factor. Okay, so again, to show you the relationship in the Poisson's equation. Now, how do you address a small aortic root and try to favor the patient give him a favorably bigger radius, a bigger effective orifice area, and give him freedom from both symptoms and from death. Increase his LV mass regression, make his NYHA class better, and delay mortality. So there are different ways in which you do it. You can approach it from the anterior, as you do in the corner procedure, Kono-Rastan procedure, or you can approach it via the posterior, where you have the Nix procedure, the Nunes procedure, and the Manusian procedure. So you remember the Anup-Sood diagram. So you know all the relationships of the aortic root, both on the lower down and both above. So, and I told you, whenever you do your aortotomy, you tailor it in such a way that you should be ready to get into opening it up further if need be. Okay, so if you go across the NCC, it is called a Nix procedure. If you go across the NCC, LCC commissure, it is the Nunes procedure. If you continue that further down into the AML and you put a patch from the AML, then it is a Manusian procedure. When you put the patch, you do not pull up the AML, so you don't need to worry about any MR. Okay. This is the anterior root winding procedure, or the Kono-Rastan procedure, where you go across the septum and you really widen it out. And this is used by the pediatric surgeons more. So that is a Kono-Rastan procedure. You put in a double patch, and one patch goes into the aorta, to the aortic incision. The other one goes into the ventricular free wall. Okay. And below both the patches go into the interventricular septum. Okay, so this is how the Kono-Rastan patch reconstruction would look like. If you so end up doing a Ross procedure along with that, it is called a Ross-Kono procedure. So you could take out the pulmonary valve, put it in the aortic valve after doing root widening, and a homograft goes into the pulmonary position. So for that, you need to have a homograft facility available. Okay, so this is the recapitulating Nix procedure here, and how much enlargement you get in the Nix. The other one is a Manusian, where the patch goes right into the AML. So you will probably get a little bit more in the Manusian than in the AML. So what are the pitfalls of all these? We talk as though, it's just so easy, just, you just cut in through and then, you put in a much bigger valve. If it was so easy, then why is it not so popular? There are some problems which are associated with this. You need to place your patch and your sutures absolutely perfectly. You do not want any bleeding. Bleeding is the problem with root widenings. Okay, so you need to have a good enough tissue, you need to suture well, and you need to make sure that absolute hemostasis is there when you do a root widening procedure, because you may not be able to take comfortably all those extra sutures later on. So first time, perfect suturing in a root widening is the way to go. Okay. So now when you have an abnormal gradient, how do you address it? A little algorithm here for you. When your measured effective orifice area is similar to the reference area you read off the chart for that particular valve, for that given company, for that particular type of valve, then the measured EOA is indexed for the patient's BSA. Okay. Then if it is less than 0.85, then you think in terms of a mild to moderate PPM. If it is less than 0.65, then it is a severe PPM. If it is more than that, then you kind of look into how you took the readings, and also you look into the LVOT to see if there is anything else, the LVOT. All these things were dealt with so beautifully by Dr. Sujata. She showed you all that narrow LVOT, if you remember. Okay, so those are the things you need to check out again if you get these readings. If your measured EOA is less than your reference EOA, then that means something is wrong with that particular valve. So whether the leaflet is moving properly, whether something is popping into place there, you have a look at it. So you look for prosthetic dysfunction if you get a measured EOA less than the reference EOA. Okay. So I think that is that completes a little bit of stuff about the aortic root widening, the philosophy behind it, the reasons why we do it, the reasons why it is important, and the pitfalls that you can have with the root widening procedures. Okay. Now we will. Can we have a look at the tricuspid valve? We will show you a little bit about the tricuspid valve, a little bit on TAVI, and I think we will be done. So let's have a look at the tricuspid valve now. So this is the tricuspid valve. So that's the septum. That's it. The mitral. So this is the septal leaflet. The coronary sinus is here. So that's the probe in the coronary sinus. And this is the anterior leaflet. So anteroseptal commissure, that's where the bundle is. Okay. And this is your posterior leaflet, which is a little bit smaller. So septal leaflet, posterior leaflet, and anterior leaflet. That is your coronary sinus. So when you put in sutures here, you need to try to avoid the bundle area, this area. Even if you put a ring and you take sutures, this is the area where the ring will be discontinuous. So you put a ring around this way. Okay. So when you have to take continuous sutures, when you put in a valve, you need to be a bit away from the bundle area. Try to put it go a little bit away from there so that you avoid the bundle. So that is the bundle is the pitfall for the tricuspid. Sometimes you may end up putting a valve in the systemic side in a corrected TGA. At that time, what comes to your help is that the patient anyway may be in a complete heart block. So anyway, the patient will need a pacemaker. So you just put it in there and just sew it up, and anyway, the patient needs a pacemaker. So many times the reason why you may be doing a tricuspid valve replacement is infective endocarditis. And at that time, the situation is even more complicated by the fact that all the tissue is very unhealthy. So as long as you try and avoid this area of the bundle, I think we should be a bit safer than otherwise. Okay, let's go to the PowerPoint presentation now. Okay, so this is your mitral and tricuspid valve specimen, the tricuspid valve. So what is to your left-hand side is your septal leaflet. The large leaflet to the right-hand side is your large sail-like anterior leaflet. Below is your posterior leaflet. In the posterior leaflet, if you notice, close to where the posterior and the anterior leaflet join, there is a little scallop. That scallop is supposed to be where the first
tricuspid valve leak jet starts. So that is where it first dilates, and that is where the first leak starts. And there will normally be a small little scallop, which is seen so beautifully here in this particular specimen. Okay, so that's the bundle. That's what I wanted you to be very careful about. So in the bundle area, you try and go away from the bundle so that the bundle is spared and the valve is still in place. And for a tricuspid valve, it's always better to put in sutures which are interrupted, especially because then you would have infective endocarditis, and if it so affects the sutures and one of them cuts through, you still have other sutures to hold it, and then the paravalvular leak is not so horrendous. So this is a working tricuspid valve. This again borrowed from the cardiac morphology July sessions. So coming July, it would be nice if you could, if all of you could be there to have a look at whatever we have to show you. This time, I think we would be specializing on the Sennings operation. So it would be nice to have you there with us at that time. So this is a operative picture of a tricuspid valve having a bioprosthetic valve. Normally, we use a bioprosthetic valve in a tricuspid position. The mitral valve has a bileaflet valve, and that is seen on the other side. Okay. Okay. So I think we will now move on to a bit of TAVI. TAVI seems to be the in thing today. But it did not all happen in a rosy way. People had to go through a lot of research, a lot of experimentation, a lot of problems. And then once it has become very smooth, now, we hardly bat an eye doing a TAVI. So what are all the pitfalls that can be when you do a TAVI? It's a valve implantation. Remember, it's not a valve replacement. So the word TAVR is to be avoided. It is not grammatically or meaning wise correct in any way. It's a TAVI, it's an implantation. So here you find the valve being implanted using this balloon, which opens it out into the aortic position. Most of the pitfalls there as cardiac surgeons, where we are mostly involved with the access, is about deceased. The patient is very old. Patient is not very fit for a surgical procedure, which is why you going for a TAVI. So in these patients, access bad vessels, atherosclerotic vessels through which you get an access. So these are all can be pitfalls. So if you do not have a very healthy vessel, feel free to sew a little poncho onto a little graft onto these vessels and use that for access. And once the procedure is finished, you can just close the graft over itself and excise the excess of the graft. So that would be a way to work around deceased vessels. Okay. Okay, so once the valve is implanted, there is an aortic root shot showing you a very competent aortic valve, and there are no gradients as measured by the TE. So what can go wrong? Many things can go wrong. I told you access. Now the non-access ones you see here, this patient has got a ventricular septal defect or a rupture that has happened because of this. So you will find that there is the dye going into the right ventricle. Okay, so this is something which can go wrong. The other one is the valve is not properly implanted, and there is very significant aortic regurgitation. Okay, so this patient has got significant aortic regurgitation. So how do you tackle this patient? Actually, both of these patients were tackled by putting in a valve in valve. So what one does is, you take another TAVI valve and you place it within this TAVI valve. Okay. When we were talking about aortic bioprosthesis, I told you a TAVI-friendly bioprosthesis is what is preferable. That means when the bioprosthesis degenerates, we can put in a TAVI within that
and avoid surgery, especially a redo surgery. The same thing applies to a malfunctioning tabby. You can put in a tabby for a malfunctioning tabby, and that is pretty much done in the same way. So if you look here, this is a video of a valve in valve, and this valve is being put into a malfunctioning valve, actually the previous one, and that sorts out the problem for us. So the role of the cardiac surgeon has now come to mostly access and a little bit of participation in the aortic, because mostly it has become transfemoral ones. The previous days when we used to have trans ventricular tabbies, the surgeons had a much greater role, and we used to do it like how we used to do closed mitral commissurotomies. But nowadays, with better and better hardware, it becomes easier and easier to do, and more of cardiologists are venturing out into that. So I think that kind of summarizes the TAVI bit. The research in valves itself is a huge arena by itself. A lot of pitfalls can happen with valves and valve technologies, which is why you need to be able to know which is a better valve for you, the valves that you would choose in a given scenario, which valves have lower gradients, which valves last longer, structural valvular degeneration, which valves you need to be wary about, which valves you can be more comfortable about. In having said so much, you need to be wary about all valves, which is why valve repair is probably something which is more desirable than to replace your God-given valve with a man-made valve. So do not do any valve replacement with impunity. If you can replace, if you can repair a valve, go all out for a valve repair. When you cannot repair a valve, and a repaired valve will last lesser than a replaced valve, that is when you actually go in for a valve replacement. And we used to have the original ball and cage valve. Then we had a lot of tilting disc valves. Once the bileaflet valves came about, we kind of got stabilized with bileaflet valves, and now most people use bileaflet valves. One of the pitfalls with valves, especially when you put a valve in and when you try to rotate it, is the valve leaflet can break. I have seen any number of times the valve leaflets breaking and getting into unretrievable areas that we had to take the patient to cath lab to find out exactly where the leaflet is to pull it out. So if you end up rotating a valve, use the holder which is given along with the valve to rotate it. Putting in instruments and rotating the valve is probably not a very great option to rotate valves. So that is something which you need to always worry about. And don't touch the valve leaflet with anything other than the soft equipment that is given for that. Many of these valves are plasma coated, and that is to make it less hydrophilic and more hydrophobic. That makes the angle of contact different. When you put a little drop of water on a valve leaflet, which is not plasma coated, it would be like this, which means it is more like a bit of water on a tile. If you plasma coat it, it becomes more like a bit of an oil on a tile or a bit of mercury on a tile, where the surface tension becomes different and the angle of contact becomes different. So it is plasma coated to make sure that the blood does not clot on the valve. So by going and scratching the valve, you make it more clottable than not. So avoid touching the valve unnecessarily, and put a little bit of water so that it's a little bit wettish, so that blood doesn't dry on the valve, and that is not a very advisable thing to have as well. With regards to bioprosthesis, many tissues have been used for bioprosthesis over the years. So, can you make that just okay? So, many tissues have been used.
Bovine pericardium is one. Porcine valves is one. Kangaroo valves, equine valves. Somehow over the years, my favorite has been the porcine valve. So this is a video of a porcine valve that I so much love. This particular valve is the mosaic valve. You find that it opens so beautifully, and the effective orifice area is very good, and it closes. You have the vortices work very well. It is like a rose petal, the valve. It is not flat like the pericardial valves. So the closure is much more physiological. So even though the leaflet actually looks flimsy, the strength is probably much greater, and the factors which disrupt the valve would be less because it is more physiological shape rather than the flat sheets which are being used to make the valves, which would be actually, even though they appear thicker and tougher, they would be subject to a much more distracting forces when the valves open and close. So this is a real beauty, and I wanted to share this with you. What would be a even more beautiful valve is this. Can anybody recognize what valve this is? Don't tell me this is the natural God-made valve. Probably you're right. This is a homograft. So the homograft valve has been put in as an inclusion cylinder within the aortic valve. So these valves, they have the lowest gradients. Okay. So you find that the flow is absolutely laminar, that's no turbulence, and the gradients are as low as 2 and 4 in these homograft valves. So if you have a homograft facility and you can use these valves, there is something which is to be desired as well. So a homograft valve is a good valve to use. So I think we've talked a lot about the various pitfalls that could happen when you implant your valves. The most important thing that will help you avoid problems, avoid pitfalls, is the knowledge that these can happen. When you put in an aortic valve, it can affect the mitral. When you put in a mitral valve, it can affect the aortic. So you need to know that these are all interrelated. They're close by, the anatomical relationships, that you can actually have a problem, that these things can happen. The knowledge that these things can go wrong, and they can go wrong in these ways, is of primary importance in avoiding these problems. And in case these unfortunately happen, we need to be able to know how to tackle them. So you need to have the solutions at the back of your mind, how to tackle these problems. And many times, a senior colleague may give you a hand in tackling a problem that you end up having these problems. So getting the help of other friends and colleagues is no harm, is actually much more advantageous. So I would advise people to, to equip themselves with this knowledge, equip themselves with friends who would help out, and keep sharing the knowledge, sharing their experiences, good and bad, so that our patients would keep on getting safer and safer in our hands. I hope you enjoyed this, and thank you for having you with us. And we would now like you to have a look at our team. We thank the Medtronic company for having provided us the valves which we used at implantation. And we thank them for arranging some sutures and some help with this. So now we would invite the company people to give you a small talk, which would add to our knowledge base as well. So let's get the team here, and then we will hand over the thing to the company. Dr. Sujata, our anesthetist.
Come on, guys.
You need to go a little bit back to get everybody in view, and then you can join us. Come. So these are all our students who help us. Rekha is my assistant, been there for so many years. She prepares all the specimens and helps out with that. Dr. Soumya, Dr. Vijay, come. And the team is not complete without our nurses. And Santana, come guys. Jasmine, Dr. Suresh. Dr. Suresh is my trusted colleague. He always comes in to help out whenever the going gets tough. So he's there for us. And so our little team here at Madras Medical Mission, team is even bigger, but we just thought we'll put together this little program for you. And owe to the sponsors to add to our knowledge.
A warm good afternoon to all of you. Myself, Santana Krishnan. I'm the regional manager for cardiac surgery business, Medtronic. Thank you everyone for joining today's session. And I will like to invite our colleague, Nikita from our sutures team to share a presentation on the various range of sutures that Medtronic provides. Over to you, Nikita. Nikita, are you there?
Yes.
Yes.
Okay.
You can go ahead sharing your screen and present.
Is Deepa going first, or would you like me to go first? Just share my presentation.
Nikita, you can go ahead.
Okay.
Yeah.
Just let me know if you're able to see my full screen. You can. Okay. So hello everyone. Very good afternoon. To all of respected faculties and all the participants who are there in today's workshop. It's an absolute pleasure of Medtronic suture team as well as cardiac surgery team to be partnering for this particular workshop. I really thank Dr. Jacob as well for giving us this opportunity. I'm Nikita Sharma. I lead marketing for the wound management portfolio of Medtronic, and I will be giving an overview of the suture portfolio that Medtronic and some of the CV specific sutures that are extensively used across the globe. To the next slide, I am very happy to share that we have a very strong heritage of wound management portfolio in Medtronic. It goes back to 1909. That's when we started manufacturing sutures. Come a long way, delivering some of the most innovative and revolutionary technologies in the market. For example, the recent one is V-Log device. I'm sure you all are aware. We are market leaders in the BARP technology, and many other sutures as well, such as Pro, Maxon, Polysorb, etc. This slide is to give you all an overview of the entire portfolio that we have. So we have range of sutures from absorbable to non-absorbable to BARP sutures. And within absorbable, as you can see, there are multiple sutures, braided as well as monofilament. And these sutures differ in terms of the absorption profile as well. So some of the widely used absorbable sutures are Polysorb. Now this is a mid-term absorbable suture, very relevant for soft tissue approximations. It has an excellent strength over the critical wound healing period and excellent knot security and handling properties as well. It has a very predictable absorption profile, and which is the most widely used suture in the market, Polysorb. Now we have Caprocin, and definitely this is the fastest absorbable suture. in the market available. It because of its faster absorption, there is less material in the body, less chances of infections, and it is a very apt suture for skin closures. Now, Maxon, is a long-term absorbable suture where you need more strength, and it is ideal for fascia closures. It offers superior tensile strength again, and throughout the critical stages of wound healing, it delivers the strength. Right, so these are some of the most widely used absorbable sutures. Now, today, particularly, I want to emphasize on non-absorbable sutures, which are mainly used in cardiovascular surgeries. SurgiPro, which is a monofilament suture, non-absorbable monofilament suture. This is widely used in anastomosis in CV surgeries such as CABG, valve replacements, etc. And I'm going to be talking about some of the improvised features SurgiPro 2 strand, in the next slide as well. We also have Ticron, which is a synthetic non-absorbable braided suture. Because of its uniform process, it is designed to provide resistance to breaking, and it has an excellent knot security as well. Just a quick overview of the barb suture. As I said, we are market leaders in V-lock technology, which is, it is a barb suture. It doesn't need to tie knots, and which is why, and our barb suture has a unique dual barb design, which offers, it is proven to lower complications in patients, and it improves patient outcomes significantly while saving the in the surgery, the overall suturing time, as well as, it delivers patient outcomes as well. I'll go back to the next slide, which is particularly on SurgiPro 2. Now, as I said, SurgiPro 2 is a suture which is extensively used in CV surgeries. I'm very happy to share that we have a stronger strand now, which is more resistant to breaking. And it is because we have listened to the voice of the customers, and we went back to our R&D, and we've come up with a stronger strand now. The diameter of the suture has now increased a little bit, is providing more strength and resistance to breaking. We have 10% improvement in the overall tensile strength now compared to the legacy product. We have 5 greater knot pull strength versus competition, and an overall 10% elongation as well compared to competition. And finally, I want to, we have not launched this needle yet, but very soon we will be launching CardioPoint needle, which is a unique design and very apt surgeries, and it is going to be compatible with all the sutures that are used in CV surgeries. And I want to show a small video, to all of you before I wrap up my presentation. Thank you very much for patiently listening. In case you have any questions, you can get in touch with our local rep in Chennai, or alternatively, you can write to me as well. Thank you. Over to you, Deepa.
Thanks so much, Nikita. Thanks a lot. One sec, I'm just sharing my screen. So firstly, good afternoon, everyone, and thank you very much, Dr. Jacob, and the entire Triple M team for allowing us this opportunity to present about our products, and also for attending a very, very innovative and very interesting workshop today as well. So I'll just take the opportunity to present a little bit about our latest wall, which is in the market, which is the Avalis wall, which is our latest pericardial wall. So before I start the presentation, I'd like to play a short video. So I'll just start the video right now, and post that I'll just take you through the features and benefits more in detail. That was the Avalis valve. So now just taking you through a very short presentation about the features and benefits a little more in detail. So just a minute. Okay. So firstly, the Avalis technology is pretty much showing us about how our tissue technology has been evolving across generations. And the whole reason behind this evolution itself is the fact that we want to mitigate the action of glutaraldehyde, and also to increase the action against calcium as well, calcification too. So that's what has actually resulted due to that, is that we've ended up with actually giving AOA treatment, and that's one of the significant features of our new valve as well. So I will just take you through what exactly is AOA, as well as what exactly is physiological fixation too, and all these features have been pronounced in the Avalis valve. Coming to Avalis, the key features and benefits are the fact that it has a low profile. It's been also a future-ready valve. It's been designed for further valve-in-valve procedures. It also has a large EOA, and we're also claiming that there's no central regurgitation. The AOA treatment is what prevents anti-calcification, so I'll come to that later in further slides. It also has a flexible sewing cuff, and it is a bovine pericardial valve, and these are the sizes which are available. So with Avalis, we say that it's completely all about the design, and we say that we've pretty much taken all our 40 years of heart wall innovations that we have, and we've pretty much taken all design concepts and adapted them, and that's how we pretty much brought about the Avalis valve. So we're saying all the proven technologies plus extended durability, performance, ease of implant, and lifetime patient care is what the Avalis valve really gives you. I'll be taking you through each of these pointers specifically and talking about the innovations we have done there. Firstly, coming to durability, the valve design itself is being designed in such a way that it's it is a durable wall. We have about 3 laser cut bovine ferricarded leaflets. The most important fact to be noted here is that these are all internal mounted leaflets. So then the damage to leaflets is minimal. It also has a supra-annular design. So again, like I called out earlier, it's it's completely future ready for any TAVI cases which may happen to the patient later on during his lifetime. Coming to the dual component peak stent, so we actually have a stent frame which is got dual components. The first part of it is the non-deformable firm base frame. So this enables that the wall maintains its circularity. The second part of the frame is a tri-leaflet flexible stent frame, which actually enables that the wall functions much better. And this is also what minimizes the central regurgitation too. It also helps to mitigate stress zones and helps us to enable better performance too. The advantages of this is that it gives better strength and flexibility. It also is able to resist permanent deformation, so it has no memory. The most important factor to be noticed here is that there are no metal components in the Avalis wall, so it's completely MRI safe. With the future valve-in-valve procedures, the peak base frame is impregnated with barium sulfate, so it also provides radio opacity as well. So that's about the durability piece from the structural part of it. Coming to the treatment, we have an EOA treatment which prevents the free aldehydes binding to the calcium, and this enables the fact that the valve is much more durable, and it prevents calcification also. And this is a technology that's been used by Medtronic for over 20 years. And this is what is being used in the Avalis valve and also in our TAVI valves as well. Coming to hemodynamics, we are ensuring that the supra-annular design, the base frame, which I already called out, it resists permanent deformation, no memory. All these factors actually enable better hemodynamics in the valve itself. And again, supra-annular design is also able to contribute to the same. So I've already mentioned this. Moving on to ease of implant. This is again a very key feature of the Avalis wall. It has a low wall profile, also has like narrow stent posts, which enable that you're able to implant it much easier. There are very clearly called out sewing markers, which is already mentioned over here by the arrows, which enable the surgeon to actually place the valve in a correct manner. Coming to the soft and pliable sewing cuff, again enables ease of implant too. There's also a streamline holder which enables better viewing and access to, and there's a one-cut release, which is the most important factor. So you don't, the surgeon finds it much more easier after sewing the valve to release. Moving on to the design goals, again, we have a procedure of a single 30-second rinse procedure, which reduces the time before implant too. And I've already called out the other features on the previous slide. Okay, these are all the sizes that we have available. Coming to lifetime management, the advantage, again mentioned it in the previous slide, saying that the entire valve is designed for future valve-in-valve replacements. We have interior mounted leaflets, and there's also a low profile which minimizes risk of coronary occlusion. Again, it's non-metallic, so it's completely MRI safe. And the peak base frame is impregnated with barium sulfate, so you're able to visualize it, and it's radio opaque as well. That's exactly what it looks like in future TAVI procedures. And thank you very much. That's all I have for you. Thanks a lot to the entire team at M, and thank you, Dr. Jacob, as well.
Yeah, thank you so much, Deepa. Deepa is our product manager for the cardiopulmonary products. And thank you, Nikita, as well, our suture product team. And on behalf of Medtronic, and I also thank Dr. Jacob, sir, and the entire team of Medtronic, Pitfalls for this successful event, and hope we will do all soon with another new edition of Science and Technology. Thank you, everyone. With this, we end the meeting.
Question? You concluded the meeting?
Yeah. So we also share. Thank you, everyone.
This thing is- I don't know why. Not that.
It's more like it's a model.
Yeah, no way. Actually, nobody shows all these things. We have to make it very, very learning friendly so that everybody can just
Come. We'll go there on Thank you so much.
Who's this? Justin, who's this? Huh? Yeah, Kamal Dana, sorry. We want your valves, we keep it.
No, sir.
We can keep it. We can keep the valves. We keep it in my room. Next time we need it, we can use it.
No longer.